I'm stepping in the OR now.
I'm just running ads. Just let me know when you're ready to start. I'll give you the 3, 2, 1.
Okay. I'm ready whenever you are, so just give me the 3, 2, 1 when you're ready.
Okay. All right, doctor, you're live in 3, 2, 1, go.
Good morning, it's Dr. Duke Majan, and it is now August 24th, 2021. We are broadcasting live spine surgery from the Duke Spine Institute and Surgery Center of Viera. We broadcast all of our surgeries live, unedited around the world for anyone who wants to watch and learn. And you're welcome to ask questions. If you have a question, please type it into the dialog box. We're broadcasting over YouTube, Facebook, Twitter, called Periscope, and I think we've added LinkedIn. I don't know if we've added LinkedIn yet, have we?
We will for the next week's stream.
Okay,
yep.
Good. All right, so the surgery we're doing today is on a patient who has actually 5 herniated discs in his back. Morning. And he has numbness, tingling in his right leg from pinched nerves, and he's got back pain in the lower back. So what I would expect is that the lower discs, 4, 5, 5, 1, are causing the back pain, and that all the discs are pinching nerves, causing what's called a polyradiculopathy. Radiculopathy means dysfunction of a nerve root, whether it's cervical in the neck into the arm or lumbar from the back into the leg. Radiculopathy, there's 5 nerve roots in the neck, 5 nerve roots in the back. They go down the leg or down the arm, and he has pinching and dysfunction of those nerve roots. So we're going to fix that today. Okay, sir, Dr. Duke here. You've watched my surgeries online, and we're going to get started, okay? Now, in the beginning, you're going to be awake until I get into the position where I need to be safely, and then we'll put you to sleep for the actual surgery part, okay? If you feel pain and it's bad, just say ouch. Tell me if it's your back or your leg, okay? Say ouch back or ouch leg. I can't hear you that well, so the anesthesiologist will be listening and tell me.
Okay.
All right. At first, are you comfortable?
Yeah.
If you want to move a little bit, this is the time to do it, to get comfortable.
I feel pretty good.
We'll put you to sleep in about 20 minutes, okay? All right, so the first thing I'm going to do is give you some numbing medicine. All right? So you might feel just a little, that's my finger pinching you, but you'll feel a little stick and burn, and that's normal. Now you traveled from Fort Lauderdale?
Yeah.
How do you like living down there?
Well, it's getting a little crowded.
Getting a little crowded?
Yeah.
All right. Well, we're not too crowded up here yet, which is nice.
What made you pick the area?
What's that?
What made you pick this area?
Why did I pick it? Sorry about that. I know, that's just a local going in. Relax, just relax. You're doing great. That's normal, okay? I'm sorry. That's just the numbing medicine going in. We're said. Huh? Oh, you gave him a little. He's just very responsive to the needle stick, so.
Yeah.
But keep an eye on him.
Once you get in there, I had his pressure pretty good until you started talking.
Yeah. Till I woke him up. All right, we got 9 cc's of local injected. Needle is down.
So they're going to numb you up, and then once you're numbed up, you're going to be fine, right?
Yeah. Just to let me know if it hurts. Try not to move your body around, okay? So I came here because my wife, who I met in residency at UF in Gainesville, she's from Tampa, and she didn't want to go back to California because she's her family's here. So I was going to head back to California when I was done with my training at UF in Gainesville, but of course, plans change. And so we started looking for a job in Florida, and the hospitals in this area needed a neurosurgeon, and I needed a job. So I thought it was a good area because I don't like a lot of traffic. I'm like you, I don't like a lot of just overcrowded. I can't stand that, to be honest. I don't know how people live like that. Sean? So I was attracted to this area, lateral. And it was not overpopulated, no traffic, no smog, no congestion. So it was kind of a nice area to move to. And it was near the beach, right? The beach is always nice. Who doesn't love the beach? Right? So that's how I got here. I worked for the hospital for a few years. Let's try to get 5'1". 5'1" is always the bane of my existence. You're looking down the facet joint. You see that? At 4'5". So I think we need to do either, I don't think you need to wag much, but I think you need just a little bit of orbit. Maybe 1 degree. Try it. See if you can make it better. It's not terrible, Jordan, to be honest with you. It's actually pretty good. I don't know if we can improve it a little bit. I want to see that foramen a little bit better. That's all. Just play with it. So that's how I ended up here. You know, I got recruited by 2 hospitals. I think the other way, maybe, or more, one or the other. And to be quite honest with you, after working for the hospitals for a couple of years, I was like mortified. I just got so, let's raise the fluoro, I guess, a little bit, just a tiny bit. Because the reason is what I saw happening in the hospital shot was a degradation of the quality of care. Massive degradation. What do I mean? Okay. Well, I made it a requirement that the hospital buy me all the equipment I wanted when I signed up. All right. So I wasn't going to go unless they bought me the equipment I wanted. I feel like we're off. Let's try orbiting the other way. So I had them spend $2 million to buy me the latest equipment. And I used that equipment for about 10 years with them. But there are some changes that were made. I think that's better. And one of the changes they made was they basically fired all their anesthesiologists and they hired nurse anesthetists instead. And when that happened, that really bothered me because I don't think that was an improvement in quality. It went the other way. I think you got to go the other way or something. I'm not seeing the foramen very well. So that really bothered me that they didn't value the anesthesiologists because the anesthesiologists were really good anesthesiologists. They did a great job with the patients, and I think you overcorrected a little bit. You're almost there. You're like half a degree off. I think, yeah, a little bit worse, but we're not far. So when they fired the anesthesiologists, and the reason, I'm going to tell you why they did it, because the anesthesiologists make about $200 an hour minimum, 200 to 250. Well, Medicare and the insurance companies kept cutting and cutting what they're paying the anesthesiologists to the point where they're paying the anesthesiologists $90 an hour. And how the heck can an anesthesiologist survive on $90 an hour? So they required that the hospital subsidize them. Are you still trying to find this? I think you're way off. Bring this down. So the anesthesiologists needed to be subsidized further. And so they asked the hospital to pay them to subsidize their income. And the hospital did it for years. It's blurry. Wow. Try going the other way. I mean, this side up higher. See what that does. I think it's getting worse. Yeah, it's worse. Go the other way. A little more. Try a little more, see what happens. It's worse. Go back the other way. I mean, the sacral alar is lining up, but it's not lining up with the foramen. So the foramen must be some scoliosis at 5-1. Even though we're going right through the sacrum nicely, we're still rotated. So let's find that plane. I think you may be right with, what was it, my side down? Just go down a little bit, huh?
On the left, he's just going down there too.
Little bit.
Right.
Yeah. A little more. Let's see if we can open that foramen up. I just don't know. It just kind of looks worse to me. All right, try coming back a little bit. All right, Jordan, any ideas here? You've been kind of taking them through the arcs while I'm talking. I don't know, the wag isn't that bad, but you can try it. And when we're looking right through the 5-1 disc space, maybe. Let me have the orbit. Try that. Seems to be a little better. Let's release the wag. Shot. Lock it down. How collapses 5-1? Should be something there. All right, let's try that. Numbing medicine. Just relax. Try not to move your body. Just say ouch if you feel something. 5-1 is always the hardest to do. Shot. Shot. So I'm on the facet. Shot. 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 Yeah, that's all right. Everything's going well for you, Shot. Just give me an AP. I think our orbit is still off a little, but let's leave it for now. Okay. Go back to a lateral. Shot. Uh-huh. Shot. Shot. How did that happen? Is your arc loose, or what happened there? Understood. Okay. Shot. All right, yeah, I don't need a play-by-play. Just let me know if it's really uncomfortable for you. It's going to take a little maneuvering to get to where we need to go. You're doing fine. Everything's going fine. Trust me. This is the hardest one to do, 5-1. So once we get this done, the rest will be not as difficult. I'm going to go out on a limb and say that. Sean? right? You never want to jinx yourself, but yeah, you got a lot of arthritis down here. That's the problem. All right. Shot? 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 You okay? Can you go AP? You're doing great, by the way. Everything's fine. I'll let you know if we're having any problems whatsoever. Lateral. We're getting there. Nice and slow, but it's looking good so far. All right. Very good. You comfy? Okay. Shot. Oh, I can't even see that. Shot. There's no way. Shot. Where do you feel that? Oh, is that it there? Give me an AP. Just your back, right? Just a quick AP, that's all. Right there. Shot. Okay, lateral. You're doing fantastic, by the way. Knife. Incision. How long have you guys been married? 37 years. Wow, that's awesome. All right. Shot. We need to get 4-5 lined up. Just take it easy. You're fine. Num num. Huh? Where's Jeremy anyway? Huh? No? That's looking good there. I think we need to wag a slight amount. So for those of you watching the surgery for the first time, this patient has a 5 disc herniations and 5 levels of stenosis. So there are 5 levels that need to be treated. And what we're trying to do is get rid of his back pain and his leg symptoms. The leg symptoms come from the nerve root. The back pain, I think, see the pedicle of 4? It's just slightly off. Maybe a degree, one way or the other. So to get rid of the back pain, we need to treat the annular tear in the back of the discs that are causing back pain, which I believe is 3, 4, 4, 5, 5, 1. To get rid of the leg pain, that's good. We need to unpinch and get rid of the herniation just in front of the nerve root. So we're going to try to achieve both goals today, which I expect to be able to do. Shot. But we're going to do it in a way that other spine surgeons don't know how to do, because just lay still, you're fine. They don't know how to do this surgery. This is endoscopic spine surgery. So we're going to do endoscopic spine surgery. There's only a few surgeons in the United States that do endoscopic spine surgery, but I understand. It's just breathing or what? Do we have them on a different kind of pillow? Shot? So there are some endoscopic surgeons, but most of them do what are called discectomy. And discectomy is a different procedure. They're going in and taking out a piece of herniation that's pushing on the nerve root, which is what we're doing today as well. However, they're not doing what's called an annular debridement. And an annular debridement is the key to successfully eliminating the back pain when it's coming from a herniated disc. AP? So what causes back pain? There are facet joints that cause back pain, and there are discs that cause back pain. Of course, there's tumors, fractures, and infections, but those are rare. And when a patient doesn't have a tumor, fracture, or infection, lateral, and they have back pain, it's probably coming from a injured disc or a facet joint, or both. In the case of this patient, he has disc pain from the annular tears in the back of his disc, but he also has facet pain. So we're going to treat both today. I think you're off a little bit with your wag. I'm using the X-ray to navigate. So the X-ray machine helps me find the safe passage to the disc that I'm fixing, but it also allows me to count my levels and figure out where I'm at. That's not, yeah, keep going until you get it right. So there's still a wag issue. That's better. Yeah, that's better because the pedicles are lined up. Now, do you see how the position of the needle at L45 changed with the wag of the fluoro? I didn't touch the needle. It's not moved relative to his disc. But because we corrected the fluoro picture and made the fluoro picture proper, we now know exactly where the needle is. And it's different than where it would appear to be on the last picture, which was an incorrect picture because it wasn't lined up properly. So having your navigational system lined up properly is a very important part of having a safe and successful surgery. You must have good navigation. We're navigating to somewhere in the body, and we can't see that place with our own eyes, so you must rely on something else like the X-ray machine, okay? And that's what I'm doing. So we're doing fluoroscopic navigation. What? I couldn't hear him. Yeah, I'll do one more. Just lay still. Just talk, but don't move your body, okay?
My only concern is that I go through these things. I mean, after all these days.
Don't you worry, my good friend. I want to just do a shout out for Luis, okay? And by the way, this patient who we're operating on has watched me operate many times, and he loves the dynamics in the operating room. So when he and his wife met me yesterday, they were talking about some of my past surgeries. We need the table down a smidgen or the fluoro up, either way. Table down, probably ½ inch. And I want to just say Luis is amazing. We wouldn't be able to do these surgeries without him. So we're very fortunate that he's here helping us. And that goes for the whole team. But I just want to do one specific shout out for Luis. Yeah. Luis has helped me so many times get out of, not trouble, but get around issues, you know. And that's something as a surgeon you really have to do. If you've got a team you trust, which you should, always have a team you trust. And earlier I was talking about the hospital and how I left the hospital because of the quality of care just dropped. I mean, no anesthesiologists. The circulators in the OR were always changing. Those are the nurses. And they didn't know anything. And they didn't give a shit, okay? They didn't care. Like, they would put a new circulator in my room. I'm doing these complex spine surgeries with multi-levels of instrumentation, osteotomies, and fusion. And they would have a new circulator in there that I never met. She didn't know anything about what she was doing. And you're asking for things that you need, like urgent because the patient's bleeding. And they're like, I don't know, where's that? And they just don't seem to care. So that deterioration of quality was a very big factor for me in moving my surgeries out of the hospital. Plus there were medications they weren't willing to provide because they were too expensive. They didn't want to spend the money on them. Sean? Like Exparel, for example. How many arguments did I have with the pharmacist, the head of pharmacy, about Exparel? Exparel is a non-narcotic, very safe pain medication, Sean, that I use all the time with my fusions. And it allows us to do the surgery safer and outpatient. And they didn't want to provide Exparel because it's expensive. There's a huge herniation here. I can feel it. Hey, you can feel it? Yeah, it's huge. 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 As some of my New Yorker friends say, right? Huge.
Doctor,
That's 3-4.
Doctor, when you're ready, we have a few questions.
Okay, just so before we go any further, I want to finish up. That was 3-4. So we've actually accessed 3-4, 4-5, 5-1. We haven't even done your discograms yet, and we did it all through one incision. So I'm going to do a second, and we'll get the last two discs. Okay? But I want to just keep going on this hospital tangent. Okay, I'm not trying to bash hospitals, but here's what's happening. I'm going to let everybody know the truth. Insurance companies are so greedy, they keep cutting what they pay anesthesiologists, what they pay doctors, what they pay hospitals. And hospitals, instead of fighting the insurance companies and telling them, you know, we're not going to accept lower payments, they should say, you know, to provide a high quality care to the patients, we need more money. But they're not doing that. They're just, the insurance companies keep giving less money to the hospital and taking more for themselves. And so hospitals cut. They have lower quality training for the nurses. Yeah, that's just numbing medicine going in. You're okay. They don't buy new equipment that's needed. They don't buy drugs and supplies that are needed. And so basically, who suffers in the end? The patients do. So I personally, my results of my surgeries depend heavily on equipment and staff and supplies. So if I don't have the best equipment, the best staff, and the best supplies, my surgeries, the results are not as good. And I'm not willing to compromise my surgical results for an insurance company to be more profitable. It's just that simple. And so that's why we built Duke Spine and the Surgery Center Viera, was because we wanted to be able to give the best drugs and medications to our patients when they needed it. We wanted to be able to have the best equipment and the best staff and personnel to take care of the patients. And I lost control of that at the hospital, okay? The hospital didn't allow me to do that because they were always trying to save money. Instead of fighting the insurance companies for more payment, they just would accept the lower payments and they would try to cut costs by not providing services or special equipment that was needed, okay? So that didn't sit well for me. That didn't sit well for me at all. Patients were the ones that were taking the you know, they were the ones paying the price for the drop in quality. You know, they would get pneumonia after surgery because they were fluid overload by the nurse anesthetist. They would get, you know, complications like wound complications because the sterilization wasn't done properly because they had old equipment. So, or the person that was doing the sterilizing, you know, was a loser, basically. Sorry, but that's the case. Because they're looking to save money and hire somebody cheaper. And frankly, that stuff doesn't sit well with me at all. Okay? I have a responsibility to my patients, first and foremost, to do the very best job we can do. And that's not do the best job you can do with what you have. That means to me, go out and get the best, provide it for my patients when I'm doing surgery. It's not just take whatever you're given. Okay? You have to demand the best from the hospitals. Perfect. Let's go back lateral. So when I demanded change, when I demanded improvement, it was ignored. And it wasn't just ignoring me. Of course, I'm one of their biggest producers. I made them millions and millions of dollars. But they, like I said, they just are beholden to the insurance companies, and the insurance companies started to control the quality of care at the hospital through their reimbursements practices, through how they paid the hospital. I'll give you an example. This is absolutely insane. But there's a procedure where people get narrowed arteries in their pelvis. They don't get enough blood flow to their legs. And you can fix that by open surgery, or you can fix it by grafting, endovascular. Well, the endovascular procedure came along, and the the mesh that's supposed to be put in was expensive, and it's an expensive procedure. It's actually more expensive than open procedure, believe it or not. You okay? So the insurance companies didn't want to pay for it. So rather than telling patients, we're not going to pay for a less invasive surgery for you, they went to the hospital because the hospital was just dropping their pants, doing whatever the insurance company, Blue Cross, wants them to do. And guess what happened? The hospital administration told the surgeons that have been there for 25 years doing vascular surgery, told them, we're no longer going to offer the endovascular treatment that's safer and better for patients because it's too expensive. And really what they're saying is the insurance company doesn't want to reimburse us. So when medical care decisions are made for patients by insurance companies to go cheaper, and hospitals are complying with that rather than fighting it for the patients, that is, like, to me, the final straw. And when that happened, I was the chief of surgery. I was also the chief of staff. And when that happened, that was unacceptable. And there's nothing the doctors could do. They were silenced, okay? We need to drop the table just a little bit, like half an inch. And that's when I really built the surgery center and pulled out of the hospital, because I just saw things getting worse and worse and worse for patients. And I wasn't going to stand by and allow that to happen for my patients. So I made a decision to separate myself and my practice from the hospitals. Sean? Thank God for hospitals, right? They're needed, but I just think the goals are malaligned sometimes for patient care, high quality patient care. So, all right, we'll take the questions. This is going to be the last disc we're accessing. Sean, this is the L12.
Cool. Our first question comes from YouTube. Have you ever done a TLIF?
Have I ever done a T-lift? Sorry, I chuckle a little bit. I've done over 1,000 T-lifts. I know you would never think it because you see me do laser surgery, endoscopic surgery, but I do some of the best T-lift surgery in the world because my patients literally go home 2 hours after the T-lift, and I do it open. So, yeah, I know that's your facet joint up there. Sorry about that. Yes, I've done over 1,000 T-lifts. I've been practicing medicine for 26 years. Sean? Just relax, you're fine. So 26 years, and I've been doing neurosurgery since 97. So since 1997, that's 22 years, I've done over 1,000 T-lifts. And my T-lifts average 2.4 discs fused per patient. By the way, I've actually published my T-lift results. If you want to look it up in PubMed, go to PubMed, P-U-B-M-E-D, which is the National Library of Medicine, and you can find my paper that I published about 8 or 10 years ago on transforaminal lumbar interbody fusion, T-lift. Shot? Yeah, sorry about that. We're almost done, I promise. We're going to put you to sleep soon. So my T-lift results are phenomenal. I had a 85% elimination of back pain and 90% elimination of leg symptoms with my T-lift. Yeah, look it up. It's published. Forgot what journal I published it in, but it's indexed in the National Library of Medicine. So it's the real deal, peer-reviewed and published. AP? So it's because I've done so many T-lifts that when I started doing endoscopic surgery and I saw the results were so amazing for patients and the incision is tiny. Yeah, we're too far lateral. I realized, hey, we need to change what we're doing and stop doing so many fusions because the fusions are unnecessary most of the time. About 95% of the time, you don't need to do a fusion to fix somebody. Okay, the endoscopic surgery works great. Sean? All right, let's go back to a lateral. Do I still do T-lifts? Yes. If you go to YouTube and you look up, I don't even know how they're indexed, but I have broadcasted probably close to 150 T-lift surgeries here in the last 9 years. So they're on the Duke Spine YouTube channel. Sorry, buddy. We're almost done, I promise.
Yeah, all right. My nose is
Huh?
my nose clogged up.
Your nose is clogged up? What could we do to help him? Anything? Huh? Anything we can do? Shot? AP? Let's see where we are. We may have to go a little more medial and even superior potentially. So we're on the right path. Okay, back to a lateral. Now if you look up above, you can see the T12 rib, and it's articulating next to the pedicle of T12. So we're at the L12. This will be our last disc. And then we're going to put him to sleep and get the surgery done. But I just have to access this last disc, basically. What other, I don't know if that answered the question adequately.
Yeah. Our next question comes from Facebook. Could you fuse a spine with muscular graft instead of bone?
Can you fuse a spine with a muscular graft instead of bone? No, that's not possible. Fusion requires the surgeon to use bone. Fusion is a bony process. It's basically one bone healing to another or fusing to another. You can't do that with a muscle graft. Sure. So you must use bone. So think about it this way. If you break your arm, right, what does the surgeon do? We actually put the bones that are broken next to each other and kind of close the gap between them. And then we put you in a cast. Shot. And the cast immobilizes your bones so that they don't move. Shot. Okay? And the purpose of the immobilization of the bone is to, shot? Is to, yeah, I know. Just relax. You're doing great. Shot. We're almost done, I promise. The purpose of the immobilization is to let the bones fuse together. Okay? Without that immobilization at the bony surfaces, they're not going to fuse. Shot? It's just a lot of rotation here. It's kind of what we're dealing with. You're doing fine. I'm almost done, I promise. Shot? Shot? Just lay still. You're fine. Shot? So I think that answered the question, right, Diego? Shot?
Yes, it did. What is the diameter of your endoscope?
The diameter of the endoscope itself is about 6 millimeters, and the tube that I'm using is 7 millimeters external diameter. That means the outside of the tube is 7 millimeters. Shot? So the incision we make is only 7 millimeters. Shot? Shot? You okay? This is the worst part, I promise. We're almost done. I just want to get it just right. Shot? You watched that guy I did last week, right?
Yeah.
5 levels. I'm talking to my patient, by the way, who's awake. And they all the patients that get lumbar and thoracic are awake in the beginning. Because I need his help. Sean? And he's doing a great job.
I'm ready to count
You ready to count from 1 to 100?
yeah.
What are you going to count in?
English. I don't know if you can count.
You don't know any other languages?
That, well, I can get Spanish maybe with them.
I figure you knew Italian, Sean. No?
No,
What's your background anyway, culturally?
English,
Huh?
mostly English. We didn't have
English?
you know,
Aren't you from the Northeast though, Sean?
oh yeah. Raised in Ohio.
Sean? Ohio?
That's the thing. 40 years in Florida.
Where do you feel that? AP? I don't know. I think we're too lateral again. Quick shot. Yeah. I don't know how I'm getting so far lateral though. Yeah, that's just me pushing on your back. You're fine. Yeah, that L12 is pretty collapsed. You see that? The big beak. That's osteophytes off to the side. We're not here to take osteophytes out unless they need to be taken out. But shot. Lateral. That looks good right there. See if we can make that work. Shot. 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 Try not to move, okay? I know it's a little bit uncomfortable. I promise we're almost done. If I could just access your last disc here. Give me some numbing medicine. What other questions you have, Diego?
That's all for now.
So numbing medicine is a combination of lidocaine and marcaine, and they're very effective at reducing the feeling of pain. However, whenever you're using them in a patient, you have to be aware they do have an effect on the heart and the vascular system, and you don't want that effect to be significant. So you have to keep the amount low that you use and not overuse it. Sean, sorry. Just lay still, you're fine. We're almost done. Sean? You're doing really good. I'm almost done, I promise. Sean? Sean? You mean AP? Yeah, he's got a little retrolisthesis here of L1 and L2, where the L1 is sliding backwards on L2. You can see it. Yeah, it's much better. We'll go back to a lateral. Just need 5 more minutes, okay? And you're going to go to sleep. Less than 5 minutes. Are you comfy? All right. This is one of the bigger herniations, I remember. Sean? Yeah. Try not to tighten up. Just relax. Sean? You are a good patient. Are you kidding me? All right. We've lost probably 2 cc's. 2 cc's of blood is like really 40 drops of blood. Just relax. You're doing great, Sean. We're almost done. Promise. All right. Huh? You're doing awesome. He's such a good patient. I mean, to have all this done. All right, so I tried to get everything done with 2 incisions, but I'm going to have to do 3, okay? We talked about that yesterday, just because of the angle of L1, 2, and 2, 3. All right, I'm going to show everyone, including you, so you can see this. You've got basically 5 discs in your lower back, all right? And I'm going to draw these discs right now. Let's say last one is down here. So this is L5S1, L45, L34, L23, L12. If I was going to do the alternative surgery for you, it'd be a fusion. I would have to open you from about here and 1 incision all the way up to about here. You all see that? That's literally a foot long, 12 inches incision. But instead, we're going to do the whole surgery through 3 7mm. Each of these is about 1/4 inch to 1/2 inch. Are you comfy?
Yeah.
All right. How bad is that on a scale of 1 to 10? 10? Is that where you typically get your pain? In that area? Concordant, L5S1, 10/10. So we just tested this disc and it was a 10 out of 10 pain. You could see him arch his back. It was really uncomfortable. He didn't cry out in pain because he's a tough guy, right? You are a tough guy. Is it better now?
Yeah.
Like, did it go away? All right, so remember, what are we here to do? We're here to cure the back pain. We're here to cure the leg symptoms, the leg numbness, weakness, tingling, or pain. There's 4 types of leg symptoms: pain, weakness, numbness, tingling, pins and needles. You've got pins and needles in your right leg. You've got numbness in your right leg. You have weakness too, right? And do you ever get pain shooting down your leg? Have you ever had pain shooting down your leg? Okay, yeah. So just relax. You're doing great. So, are you breathing okay?
Yeah, my nose is totally clogged up.
All right.
It's from the blood pressure.
Yeah. So, we just tested the L5S1 disc, and the tear in the L5S1 disc is positive for causing his pain. Okay? How bad is that on a scale of 1 to 10? 11. All right. So L45, was that where you typically get back pain?
Yes, I got it right now.
Yeah, but you get pain in that area. Typically it feels like that. Maybe not that bad. So that was an 11/10 at L45. Phew. Sorry about that. So we test each disc to see if they're causing back pain. Now back pain and leg pain are totally different. How bad is that on a scale of 1 to 10? 9 out of 10. All right, so L34 is a 9 out of 10. Is that your typical pain?
Yeah, pressure like pain.
But that's where you get pain in that area?
Yeah.
All right, so we got a 10 out of 10 at L5S1, 11 out of 10 at L45, and a 9 out of 10 at L34. You okay? How bad is that on a scale of 1 to 10? Is that where you typically get back pain?
Yeah, I can.
Well, all that pain's going to be gone.
Yeah.
And you actually can start to be normal again. What do we say that was, a 10?
Yeah.
All right. Well, we're going to put you to sleep now. When you wake up, we'll be done with your surgery. You can go back and watch it tomorrow on YouTube, okay? That one hurts too, huh?
Yeah.
How bad did that go up to?
That's all 10.
It's all 10. Wow. All right. I want you to count from 1 to 100 in Russian. If you get to 100, I don't pay the anesthesiologist today. All right. So you can see the alien blue blood. Our patients bleed blue for Duke spine. But just to summarize everything so far, this patient traveled here to have his back fixed. What was wrong with his back? Back pain and also right leg pain, numbness, tingling, and weakness. Intermittent sciatica. So we could have fixed his back in one of two ways. Either a T-lift surgery, which is a fusion, clean out the disc, put a cage in, do osteotomies and put in screws and rods from here to here. Okay? But he didn't want that, and I don't blame him. So he chose a minimally invasive surgery called the Duke laser disc repair. And basically it's an endoscopic surgery, and in the beginning we have to go from the outside world to the annular tear where his pain's coming from in the back of the disc. And since he had 5 discs that were problematic with herniations at 5 discs that I thought were all causing his symptoms, we just confirmed that. Every one of these 5 discs is causing his back pain. The worst was L45. That was 11 out of 10. Then he had a 10 out of 10 here, a 9 out of 10 here, a 10 out of 10 here, and a 10 out of 10 here. So 10 out of 10 pain is horrible pain. And what happens is when people have back pain like this, it's every day, all day with activities. Activities make it worse because they kind of irritate that tear and bring out the inflammation. So what people do then is they just kind of lay around all day not doing anything. And they reduce their activities. And so they become sedentary. We call it sedentary. And sedentary means just kind of like taking it easy, not really enjoying life, doing fun things and active things. Human beings are made to be active. That's how we were created. But you can't be active when every time you move your back, your joints hurt. So he has 5 painful joints. We're going to fix all 5 right now. Now he also has pinched nerves on the right side, multiple pinched nerves. So I'm going to be fixing those nerves as well by unpinching them during the same surgery. We call that a decompressive discectomy. So he's going to get a decompressive discectomy along with his disc repair. We do it all at the same time. Shot? All right, so I put my guide wire down and we're starting at L5S1. If you look at the x-ray there, I think you're too far south, Jordan. I go north just an inch. We're seeing too much hip. I want to focus on that sacrum. And can you drop the fluoro a little bit or not? All right, I think you're arced wrong as well. I don't know why, but so you can see on the last x-ray that there's kind of 2 thicker needles above and then the thinner one down below. That is the guide wire. Okay, is that my shot? You're over arced. Shot. Let's just leave it there. But again, there's too much in the back. Let's get this light off here, please. It's right in my eye. Hey, Doc, will you turn that light to you, please? The light above your head, tilted towards you so it's not in my face. You can't see anything. So we're coming down with a dilator. Jordan, I got to see the disc. Okay? No, it's not about going south, Jordan. It's about bringing the table up or bringing the floor down. It's one or the other. Come on, Jordan. Move yourself north again. Shot. All right, release the arc. I don't know why it's so hard to get the arc right. Shot. 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 shot, shot. Release the wag. Shot. A freaking mess. Shot. Shot. All right. Lock that there. He's just got a really rotated spine. All right, let me have the mallet. So now we're going to bring our dilator in. Shot. 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 Take. Shot. Second Jordan. Shot. All right, that should be good. One of the challenges of doing the surgery is making sure that your implants are in the right, or your tools and your instruments are in the right place. We're not implanting anything. We're temporarily implanting this tube. The tube's job is to retract the tissue so I can actually go down with the endoscope and do the surgery. So I have to create a portal or path from the outside world down. Shot. And I need to use the x-ray machine to help guide me. How is he? Relaxed enough? Shot. Shot. That's about as far in as I can get it. So we're going to take the dilator out, hopefully. And we'll be left with our tube. Is he comfy? All right, good. That was a tough one. So far we've lost about 3 cc's of blood. About 60 drops. And I don't expect to lose too much blood. We might lose 5 total, 5 mils, 5 cc's. This kind of surgery done open, most surgeons would lose a liter of blood. That's 1,000 mils. We're losing 5 for the whole surgery. So, you know, compared to open surgeries, the Duke laser disc repair is essentially a bloodless surgery.
Patient requests no wet food today.
Oh yeah, yeah. The surgeon's requesting dry feet.
No, also the patient, he said,
Oh, he requested,
he told me.
he wants you to make sure my feet are dry.
Yes, sir.
Nice. Okay, so we have to do that.
All right, stand by over here. Come on, please.
So we've got our tube inside the L5S1 disc. Now we're going to go down with the endoscope and get into that disc and see what's in there. All right. Yeah, it's pretty. Look at that inflammation on the right there. That's the end plate. That is the L5 end plate. We're looking right between the end plates, right inside the disc space. And all that redness and pinkness is inflammation from the actual herniated disc.
Lights off, please.
The herniated disc and annular tear actually cause tremendous inflammation. And that's where the pain comes from. This is, you know, back pain and neck pain are an inflammatory condition. They're not anything else, but they're misunderstood by most doctors. They think that it's instability. The truth is that they don't know what it is, because back pain doesn't fit the models of typical surgery. Neurosurgery is based on a principle of something called decompression. And what they're talking about with decompression in neurosurgery is getting the pressure off of a nerve root or a spinal cord. And this is not a compression problem. So neurosurgeons can understand it. And orthopedic surgeons could understand it, but they're not that many that do complex spine surgeries. And believe it or not, of all the surgeons, orthopedics are probably the most capable and trained to do endoscopic surgery. But then when it comes to getting access, that's where they struggle, is getting in. So using an endoscope, neurosurgeons struggle with. The concept of treating an inflammatory conditions, neurosurgeons struggle with. The access, neurosurgeons struggle with. There's your inflammatory tissue. So it was recently published, actually not recently, but a few years ago, that some Chinese researchers discovered that herniated discs that were painful actually have high numbers of inflammatory mediators, such as tumor necrosis factor and interleukins, that all promote basically the ingrowth of inflammatory tissue, which then causes pain because they're small nerve fibers. I've been saying this now since about 2007 when I started doing the surgery, but it's taken the rest of the world a lot longer to start catching up. And even now, most neurosurgeons don't understand, like 99.999% of neurosurgeons and most orthopedic surgeons don't understand that this is an inflammatory disease and we're dealing with inflammation. So where is the inflammation? Diego, why don't you run our animation video
Okay, I
that
will.
shows the lumbar cause of lumbar back pain, lower back pain. And you'll see as he's running the animation video that there's a tear in the back of the disc, which is what we're targeting here, and pushed through the tear is the herniation. And it's the herniation inside the tear that is a combination of that causes the inflammation and back pain. And that's what we're here to fix. Keep an eye on those needles. It's not really that good there. I've got to back this tube out oh so carefully. Here, hold this away. Because it's being compressed by the collapsed disc. So we're not uncollapsing the disc. Everyone thinks, are you fixing degenerative disc disease? We're not going to make this disc look normal, okay? That's not what the surgery does. There's no surgery in the world that does that. Except there's one where you actually take a dead person's disc and cut through the bone above and below and transplant that normal disc into a patient. Then you got to put them on immunosuppressive therapy. It's crazy. There's no reason to do it. But it's been done once, I think in China or Korea, one of those countries, where they actually transplanted a human disc from one person to another. But anyway, that's not the future of fixing back and neck pain. It's not totally unnecessary to do. All you got to do is go repair the annular tear and the herniation at the back of the disc, which is what the Duke laser disc repair does. The surgery you're watching right now is the only surgery in the world that does this. There are other endoscopic surgeries that take herniations out, but they don't debride the annular tear. The key to the surgery is the debridement of the annular tear. And it's our concept that I developed here at Duke Spine years ago, and we've published on it, but it just hasn't been picked up by other surgeons because they're so busy doing fusions, which pay better, quite honestly, and are promoted by the implant companies. The big implant companies that want to sell screws and rods. The same screws and rods that are used in T-lift surgeries and ACDF surgeries and PCDF and X-lift and O-lift surgeries. Hey, all those screws and rods make big companies billions of dollars. So they have a vested interest in those surgeries are being done. So they're training all the new surgeons that are in training and residency. They're teaching them to do those kinds of surgeries rather than less invasive, no implants, better results, better outcomes, faster recovery, faster return to work, less blood loss, and no narcotic surgery like this.
We have someone asking about your working diameter in the portal.
Yeah, so have you run the video yet? Are you going to run it now, or are you going to...
I ran already.
Oh, okay, that was quick. So the diameter inside here is about 6.6 millimeters across. The outside diameter is 7 millimeters. And this laser fiber you're seeing is 0.5 millimeter, the glass part. Okay? The little glass part at the end is 0.5 millimeter wide. The blue part is about 1 millimeter wide. So that gives you an idea of how precise this surgery is. You're dealing with 0.5 millimeter. So the width of the laser fiber that emits the laser beam that you're looking at, the little glass part at the end, is 0.5 millimeter. And the laser energy goes out about 0.5 millimeter. And then it becomes ineffective after that. So it can't damage any other tissues. It's very safe. You can't shoot this laser beam to the other side of the spine. You can't damage any nerves or anything with it. It only goes out 0.5 millimeter. So basically whatever it touches. So I make it touch the tissue for it to work.
We have another question.
Sure.
Can you help a person who has already had a fusion and is still having back pain?
Yeah, we get this question all the time. Can we help someone who's already had a fusion and still has back pain? Absolutely. Your back pain is not coming from the fusion. It's coming from the disc or facet joints above or below your fusion. So the first thing we can do to help you is to make an accurate diagnosis as to where your pain's coming from. So if you're fused at, say, L4-5, your pain may be coming from L5-S1, or it could be coming from L3-4. I would have to look at your MRI that's recent, and I would have to do an exam. We could do all of that through telemedicine using video conferencing, okay? And Duke Spine does that every week. We do video conferencing with patients around the world every week, and we actually provide that as a free service. So we don't charge anybody to do a video conference. We request that you submit your MRI so we could look at it first. So submit your MRI to Duke Spine, and the way you do that is you go online to the website and you fill out the free MRI review form. Your name, your contact information, so we can reach out to you. And then where your pain is, back pain, neck pain, leg pain, we're going to ask you some questions, okay? And then we're going to get your MRI. Either you upload the images, and we don't want just the report, folks. We need the actual pictures. We don't work on reports. Reports are some other person's interpretation of what's wrong. And we don't rely on other doctors' interpretations. We need to make our own. The reason we're successful is two things. Number one, we make the right diagnosis, which usually is not the same as most other radiologists. Radiologists miss things all the time. And number two, we do the best treatments in the world right here. So we need your images and we need your report. Once we have your images and report, we look at them. I actually personally look at them myself. And then we come up with a recommendation that's tentative. It's called an initial recommendation. And then we do an exam. And we do the exam through telemedicine, basically through video conferencing. So we'll set up a video conference where we can look at you face to face, and I can do an examination. And usually I have you or somebody else with you push on different areas of your back or neck to figure out where the pain's coming from and make sure that it lines up with what the MRI shows. Okay? So through using MRI and telemedicine, we're able to diagnose what's wrong about 98% of the time. And then we can set up a treatment for you or anyone to come out here and get that treatment done. It usually takes 2 or 3 days to get your treatment done, but it can all be done with a very quick visit through Orlando, Florida to where our main center is. But yes, we can help. We do it all the time. We can help people who have had fusions by fixing the painful disc that's above or below the fusion. So this is, the blue stuff is the stain that we put in, the dye. It's a blue dye, and it's like a food coloring. What it stains is it stains the degenerated nucleus pulposus. It doesn't stain nerves, it doesn't stain bone, it doesn't stain bone spurs, it doesn't stain scar tissue. It stains one and one thing only, degenerated nucleus pulposus. This was taught to me by Dr. Anthony Young, Tony Young. He's a pioneer in endoscopic spine surgery. I think he's retired now, but he was one of the first endoscopic surgeons in the United States. He practiced out of Phoenix, Arizona. I went out to his center many times and was personally trained by Dr. Young. He was literally a guru, one of the best in the world, in my opinion, a true pioneer. But he didn't do the Duke laser disc repair. He only did remove the herniation, and he didn't fix the annulus like I do. So he missed out. But he taught me a lot of the basic techniques with lower back. I had to learn cervical from the Koreans, South Koreans. They're the best in the world at the time at cervical. Back in 2006, I learned from Dr. Seng-Ho Lee, Dr. Gun Choi. You're okay. He's responding a little. I don't know if you want to make him a little more comfortable. You don't have to. I'm okay. He's not moving that much. All right. Oh, this is a lot of scar tissue here. See the yellow color? Scar tissue and bone spur. So you want to be careful. At 12 o'clock is going to be the traversing root, which is going to be your S1 nerve root. And just to the right at 3 o'clock is going to be the right L5 nerve root. Almost done here. I want to get lateral too, because a lot of people don't look lateral. If they do this type of surgery, they miss the lateral herniation. Want to make sure we get it all. What's bleeding, or that reddish color in the water, is the end plates. They're very angry from all the inflammation that's been going on. They're basically inflamed. So remember, this is an inflammatory disease. That's what a lot of doctors don't understand. So you can see how inflamed the end plates are. And they're hypervascular. They've got a lot of blood supply going there to support the inflammation. He does not like it. This is the painful area of the disc. That's why he's responding a little bit. All right, just about done. I think I'm going to take one more swoop at it. Want to make sure the nerve roots are protected. Yeah, he's moving a bit. I'm just about done here. I think we're good. I think we're good there. Stand by. All right, so we're gonna pour all the liquid out. Scope off. All right. I'm gonna do a little washout. All of our patients get antibiotics, IV, which is the standard of care. And we give Kefsol, 2 grams IV, we're really covering gram-positive organisms. That's the main thing we're covering. And gram-positive organisms like staph and strep are the most common causes of postoperative wound infections. So you want to make sure people are covered for those organisms. So we do the IV antibiotics, plus we also do betadine. Okay, so we're done here with L5S1. Going to take this out. We've been pulling it back slowly. We're going to apply a little bit of pressure to the paraspinous muscles. So I'm not worried about the amount of bleeding. It's been very minimal, but you don't want the muscle to swell up with some blood clot. Lateral, please. So I put pressure on the paraspinous muscle where the tube was for a few minutes just to make sure that we don't develop any intramuscular blood clot. Intramuscular blood clots are not life-threatening in any way. However, they do cause postoperative pain. And we don't want our patients to have postoperative pain. All right, let's line up 4-5. You're almost there. Put some pressure here. Now, we'll get the guide wire going for the next level. Thank you, Luis. I could feel the tip of it in the disc. Whenever you're ready. Good. Looks good. So now that we have the guide wire in, we can take the actual needle out shot. As I do that, I want to make sure I don't pull the guide wire out or I don't push the guide wire in. So out or in on the guide wire is bad. So you want to keep an eye on the guide wire. And the only way you can do that, obviously stabilize your hand so you don't go out or in with the guide wire, but also get x-ray shots to make sure it's not going out or in. If you accidentally pull the guide wire out, you have to start over with the needle, okay? It's not the end of the world, but you can't just, wing it. You can't just like stick it back down the hole, You have to make sure it's going in safely. Is that me right there? Okay. Now we're going to head down, relax, with the next level. I could feel the fascia, through the fascia shot. As you're advancing the dilator, you have to keep an eye on that guide wire as well. The dilator can actually pinch the guide wire. Is that where we are? And the dilator can pinch the guide wire with a little bit of tissue at the end, and it can advance the guide wire into the belly or into the pelvis, okay? You don't want that. You don't want the guide wire being advanced into the pelvis, because then it can interact with the intestines, interact with the kidneys, ureters, bladder, ovaries, uterus, all the things that live in the pelvis. And they don't want to interact with the guide wire. Not ovaries in this patient, obviously, but I'm just speaking generally. Let's see what we got. Relax. I think we're awfully close, maybe a little bit more. So we're passing the dilator through the annular tear. That's the part of the disc that's damaged and causing pain. So this technique allows me to actually enter the herniation through the damaged part, which is ideal because then you're not creating more damage with your surgery, what we call the approach, which is getting down there. So this is a wonderful surgery because unlike open back surgery, whether we're doing a laminectomy or a discectomy, you got to make a cut here, so a huge skin cut, damaging the skin. You got to peel all the muscles off the spine, and that's damaging the muscles and the spine because you're cutting the interspinous ligament, and you're damaging the muscles, causing scar tissue. And then you got to drill away holes in the spine, in the bone, which we're not doing because we're going through a natural hole. So open back surgery like laminectomy, microdiscectomy, discectomy, fusions, they all do horrible, horrible damage back here that this procedure doesn't do. That's the advantage of the Duke laser disc repair endoscopic transforaminal approach. He's a little too light. I'm going to have to strap on my sterile saddle. All right, so we're advancing the dilator and the tube. We don't want the dilator going forward any more than it is, because it'll exit the front of the spine. Shot? That's perfect. All right. I love it. My anesthesiologist has it all under control. You're getting used to these procedures, huh? You know the painful parts, and you know how long it lasts, and I like that. Cool heads prevail. So, we're getting ready to start the second disc, which is L45. This was his most painful disc. When we tested it, it was an 11 out of 10. The one we just fixed was a 10 out of 10. That's 10 out of 10 pain. That's horrible pain. Think about that. These discs are causing so much pain for this patient, and we're repairing them today endoscopically at Duke Spine Institute to take away his pain. He's going to be very happy, I believe, with these results. You have another question?
Yes. YouTube asks, how do you restore disc height in this process?
Great question. So somebody from YouTube, one of our viewers, thank you for asking, has asked, how do you restore disc height with this process? The answer, we don't. We don't restore any disc height. Isn't that amazing? We're not restoring disc height, and yet the pain is gone in their back and the legs. They go back to being a normal human being without restoring disc height. What does that tell you? It tells you that restoring disc height is overrated and unnecessary. That's what it tells you. Totally unnecessary. Because not in the 1,300 plus Duke laser disc repairs I've done, cervical, I need a laser on, cervical, thoracic, and lumbar, I have never restored disc height, not once. We're not taking any disc height away, but we're not restoring it. And yet every single patient has had their pain gone afterwards, and their radicular symptoms 98% on average gone long term. Long term 95% after 6 years. So without restoring disc height, we still have elimination of back and neck pain and elimination of arm and leg pain by 95% on average at 6 years of follow-up. That's incredible. Okay, to get rid of back and neck pain and arm and leg symptoms at 6-year follow-up, there is no other surgery that has 95% as the Duke laser disc repair does. That's an average of all the patients. This is just herniation. What we can see here is the annular tear, and we can see the herniation in between. The blue stuff is the herniation. So the tube is sitting inside the annular tear, in the deepest part of it right here. That's where we are, the deepest part of the annular tear. And we're going to start pulling this tube backwards. As we do, we're going to debride the annular tear from inside out. And then when we get to the surface of the disc, we would have debrided the entire annular tear on the right side, which is where his pain's coming from. So are all annular tears painful? No. For an annular tear to be painful, it has to be in the back of the disc, not the sides and not the front. And the next question is, are all annular tears in the back of the disc painful? The answer is absolutely not. As a matter of fact, most annular tears are not painful. So why are some annular tears painful and others are not? The answer is inflammation. When you get an annular tear, you've damaged your disc. You've damaged the annulus, okay? And to heal, it's going to become inflamed. Normal inflammation in normal healing takes 5 days, maybe 7 days, at most 14, okay? And then the inflammation's gone by 2 weeks. The problem with these patients that have persistent back pain or neck pain from an annular tear is that their inflammation doesn't stop, it doesn't go away. It just keeps getting worse, and then it dies down a little bit, then it comes back again. So why would inflammation stay and not go away? That's because the disc keeps getting re-injured. And why does it keep getting re-injured? That's because this blue stuff, the herniation, is sitting inside the annular tear, and the annular tear cannot heal itself. So it gets a little better, the inflammation dies down a little, and then it picks up again. It's like a wildfire, basically, that just won't stop on its own. It just keeps going. And your body has plenty of inflammatory cells, and it's always making more. Every day, all the time, 24/7. So there's no end to the amount of inflammation your body can support when it comes to inflamed areas of the body. Okay? What are some other inflammatory diseases? Rheumatoid arthritis. Everyone's heard of rheumatoid arthritis, right? Rheumatoid arthritis is an inflammatory condition where your body is constantly waging war against the small joints. Against the small joints. Your knuckles, your toes, small joints. So they're constantly inflamed and damaged as a result of that constant inflammation. The inflammation over years and years causes bone spurs and collapse of the joint to where it's just bone on bone, loss of the synovial tissue, loss of the synovial membrane and capsule. Just the joint gets destroyed. It looks like a city in Afghanistan or in Lebanon that's just been destroyed by war over many, many years. It just doesn't stop. You know, those cities I'm talking about where all the buildings have been blown out by machine gun fire and cannon fire, and you know there used to be a beautiful city there, but then it's gone. I mean, just look at the old World War II movies of Europe. A lot of the cities that were destroyed by Nazis or allies, either side, just destroying cities, destroying buildings, destroying structure. So this joint is a structure. It's a structure. All your joints and tissues in your body are structures. Okay? So you're destroying the structure of the disc through the inflammation that's going on in there. There's a war going on in there. It's an invisible war. You can't see it with your eye. Inflammation is mediated by microscopic cells called polymorphonucleocytes, or PMNs, and macrophages, and they come in there and they literally dump their enzymes onto the area. And those enzymes are proteases and lipases, and they just chew everything up. It's like a shotgun approach to try to destroy what the body thinks is an invader, a foreign body. So when they encounter the nucleus pulposus, which is the jelly that's normally in the center of your disc, and it's encountered now by the vascular system, your blood vessels, with the PMNs and macrophages, they identify it as being foreign, and they start to attack all those tissues, even though it's just your normal body. How many of you have seen the movie recently, about 2 years ago? It was received all the awards. It was a Korean movie. Brilliant Korean movie.
That would be Parasite.
It's called Parasite.
Yes.
Okay? If you've seen Parasite, there's a man in the movie who's been living in this house, unbeknownst to the owners of the house and their children. He's living down in a basement, tucked away and hidden. And all's well until he comes out of that basement and he gets caught. And then all hell breaks loose. Okay? Because the people that normally live there don't expect there to be somebody living in the basement of their house in a secret room. Well, that's exactly what happens with disc injuries. The nucleus pulposus lives inside the center of the disc, unbeknownst to the entire body because there's no blood supply. So it's never seen. You know, the blood supply is the way the body sees things and interacts with organs and tissues. Okay? But because the nucleus pulposus is tucked away in a layer of collagen that is like a wall sealed off from the rest of the body because there's no blood supply. And then when that wall cracks open and the nucleus pulposus comes out, the body says, holy moly, who are you? You're a foreigner. We don't know who you are. We're going to attack you. That's just, evolutionarily, that's how our bodies have evolved, to attack anything that's not known as self. Anything that in the body that's not recognized as itself. And of course, he uses a system of immune-mediated attacking and then inflammatory-mediated attacking. So, two different strategies. The disc itself, the nucleus pulposus, is not, to my knowledge, it's not immunogenic. It doesn't elicit an immune response like a virus would, where you have antibodies being produced to it. I don't know that for sure, but current research hasn't shown that. But it does elicit an inflammatory, non-specific inflammatory response. The inflammatory response is non-specific. It's not regulated or mediated through recognition, through receptors and antibodies interfacing with antigens. The inflammatory system is just simple. It's almost thoughtless. It's not very sophisticated. The immune system was probably developed many, many years later after the inflammatory system. The inflammatory system was probably the original body's defense system, guys with clubs. And the immune system is more like sophisticated laser-targeted arsenal, with intel. So we still have inflammatory systems, and we need our inflammatory system. We need the brainless thugs, but we also, sometimes they get it wrong. There's the tear, right there. They get it wrong and they attack your own body like normal structures like this. Okay? Any questions?
No.
So I'm going to talk to you all about a few things. Number one, Duke Spine Institute has an app that's free and available to everyone with an iPhone or Android. And you can go to your app store and type in Duke Spine Institute. You'll see the app. You can download it. It's free. It's a really, really good app with lots of valuable information and videos and educational stuff. It also is going to be updated in the next couple of weeks with some more content and better organization. So I recommend you download the Duke Spine Institute app. You can learn a lot about back and neck conditions from it and how to treat them. We cover topics like rhizotomies of the facets, sacroiliac joint injections, physical therapy, shots, surgeries, different kinds of surgeries. And it also has a link to watch live surgery. Okay? Then we also have on Facebook a Facebook support group called Spine Surgery Support Group. It's free. You can join. Just request to join. And the nice thing about Spine Surgery Support Group is that we don't allow trolls. Trolls are people who try to stifle the exchange of truthful and helpful information. Okay? Unfortunately, a lot of Facebook's groups have trolls. And the only two explanations for trolls are, number one, the Facebook group wants to have a select group of people it can advertise to with a bunch of nonsense like mattresses and, THC and things that don't actually fix people's pain. And they don't want someone like me coming in and telling people that their back pain can be cured. Because if you cure someone's back pain, they don't need chiropractic therapy every month for the rest of their lives. They don't need special mattresses and special pillows. We fix them. And that pain goes away. So I'm not saying those things aren't useful. Of course they are. But people should be aware of the truth. And anytime a Facebook support group blocks the truth, I get upset with that group. So I've decided that we're going to start a series of broadcasts every week. We're going to put out a YouTube video where I'm going to go and take screenshots of Facebook groups, and we're going to talk about some of the comments that are made and posted. Okay? So look for that. That'll be coming out on our YouTube channel at Duke Spine Institute in the next couple of weeks. I did my first one on the, I think it's called the Y-band. Isn't that right, Diego?
Yes, the Y band.
The Y-band treatment. Very popular right now. It's a chiropractor who basically hangs people by the neck while they're laying on a table, and people are getting excited about it. I'd be excited if I survived it as well. But again, you're going to learn that it's all, the people feel better because, number one, they survived such an aggressive assault. Who wouldn't be happy about surviving an aggressive assault, right? If someone comes after you with a gun or knife and you survive, you're going to be like, thank God I survived. I'm happy about that. But then also you get the release of endorphins and enkephalins, which are your body's natural opioids, and they create a high, a really nice high, and you feel great, and it takes the pain away. So all that's happening is this guy is just snapping people's necks and releasing their natural painkillers, and that's why people feel good right afterwards. Of course, it's going to wear off soon when the painkillers that your body releases wears off. So we kind of expose that treatment as dangerous and temporary. And we're going to be talking about a lot of things, lots and lots and lots of things. So we're going to have a lot of great publications coming out from Duke Spine's YouTube channel and our YouTube team, which is headed up by John May and Diego. We also have our Roku channel that we'll be starting to publish content on. So if you're a Roku subscriber, look for that. We're going to have our first videos in about 3 months. We also have artificial intelligence platform we're developing for our website to help people that are looking for answers to get out of pain, get out of back pain and neck pain. And we're developing an AI platform on IBM's Watson that will assist our visitors to the website and to Duke Spine. So we have a lot of exciting things happening, all state-of-the-art and all educational, to raise awareness about why back pain exists and how it can be cured. Same thing with neck pain and thoracic pain. All right, we're almost done at L45. You can see the lasers going to work here. It's just eliminating and vaporizing this nidus of pain. This is the pain generator at this disc. It's basically the interposed herniation. It's called interposed herniation that's stuck in the annular tear. And I'm debriding the annular tear. 95% of the surgery, maybe even 98% of the surgery, is debridement of the annular tear. I'm not doing a herniation removal. I'm doing an annular debridement. And that's what sets the surgery apart from all others. Other surgeons don't do an annular debridement. They don't even know that it exists. That's how far behind they are in times. And I don't think they're going to be aware of it for another 10, 20 years, to be honest, at the way they go. They're also obsessed with fusion. Look at the laser blasts on the wall right there. This is stainless steel. And every time I hit the laser and it sends a blast, it sends about 2 blasts a second, maybe 3 a second. Those blasts, every one of them creates that welding. So you know these lasers are super powerful. And there's a lot of myths and false information out there about lasers in spine surgery that they can't remove bone spurs. Oh yeah, we remove bone spurs easily. If I can melt steel, I can remove a bone spur. Bone spurs are probably 5 times easier to remove than steel. So it's just a testament to the power of the laser. And by the way, we have this laser on at about 30 watts, right? So this is a 100-watt laser. So we're at 1/3 of the power, basically. So we're not even ramping this bad boy up. This thing can deliver a lot more energy to the disc if we wanted it to, which I don't. There's no reason to deliver more energy when it's not needed. This is a green laser. We're all about saving energy. Right, Luis? Conserving. There's the last of the tear right there. You can see it. And there at the 12 o'clock is some fat and some veins in the epidural space. How are we doing with him? Any update from Mark Sinclair? Oh, thank God. You gonna be all right? We'll talk later.
We have a new question from YouTube.
Sure.
On fusion, you mentioned the importance of removing the inflammation and the
I'm
bone.
so sorry, Diego. It's just a little too not loud enough, and
Okay.
slow and enunciate your speech.
I'll put the volume up. Can you hear me better now?
Yeah.
Okay. Our YouTube commenter asked that on fusion, you mentioned the importance of removing the inflammation and the bone overgrowth at the joints. During the disc laser disc repair, is it only the disc, and will they experience the same level of relief?
Yeah, great question. So the question is, Dr. Duke, you made the point that there's really kind of two different types of joints in the spine that get inflammation and cause pain. The disc and the facet joint. So with the Duke laser disc repair, what are you doing? You're only fixing the disc, right? You're only treating the inflammation from the disc. The answer is yes. You are correct. We are not treating the facet joint inflammation. So that's what we're going to be doing as soon as I'm done. Dr. Patel is going to come in and treat the facet joint inflammation with a rhizotomy. Do we do that for everybody? No. We only do it on patients that have facet joint pain and inflammation, along with their disc pain. So not every patient has disc pain and facet joint pain. About 20% do. So 1 in 5 patients that we see here, and they're coming in for laser surgery to fix disc pain, they have disc pain plus facet joint pain. We have to treat both. So we just do it all in the one surgery, okay? What happens with fusions? In fusions, I treat both with the fusion. So when I do a TLIF, transforaminal lumbar interbody fusion, I'm treating the facet pain and the disc pain both, because I'm getting rid of their facets and I'm fusing the spine. And fusion means there's no more movement, and it's the movement of the disc that exacerbates the pain. You ever notice how if you have back pain, it gets better when you take it easy? You stop moving? Well, fusion is like permanently stopping the moving of your facet joints and your disc. But you lose movement, and you go through all that pain and suffering of having that big fusion surgery done, which hurts. And it's risky because you can get a complication, like a blood clot or pneumonia or something. So why go through that when you don't need to? Okay? As long as the endoscopic surgery, laser surgery is available to fix your disc pain, and you can combine it with a rhizotomy to fix your facet pain, then you do that. That's less invasive, less bloody. 1 hour recovery, a much better treatment than having a major fusion surgery and all the risk that goes with it. I hope I answered your question. I don't know if I did or not, but if I didn't, just tell us what I didn't answer and I'll be happy to answer it. All right, we're done here. I'm going to grab that little thing out and then we're done. So we got 3 more to go. Take. By the way, if you want to see the nerve root, it should be right there. It's in the fat. See that you can kind of see the white thing right there, just to the right of the fat? The fat is that golden, glistening little micelles. And just underneath it is the dura of the nerve root. And that is going to be your patient's right L4 nerve root. All right, I'm happy with that. Let me see the laser one more time. Sorry. Huh?
How do you feel about the methylene blue deal and the discs?
Methylene blue? I don't use methylene blue.
Or what do you use to,
Yeah, methylene blue is not acceptable. We use something called indigo carmine. Yeah, indigo carmine stains to degenerated nucleus pulposus. And that wasn't my idea. That was the Koreans were using it, Dr. Young was using it. I didn't come up with that.
there's some data that intradiscal methylene blue helping the inflammation.
Oh, really? Yeah, I haven't done that. That's a good point. I don't know. I didn't hear about that. I have to look that up.
Yeah, I got the studies on that.
Yeah, our anesthesiologist mentioned that the, lay still, intradiscal methylene blue. Just lay still, everything's okay. Let me have it now. Lay still. Pressure. You're fine. So we're, people wondering, we always want to have our patients just asleep enough that they are comfortable, but at the same time, not too asleep that they stop breathing. So there's a balance between the two. You want patients in twilight. So twilight means they're breathing and they're stable. If they go too deep, they stop breathing. So the Propofol can put them too deep. That's what happened with Michael Jackson. Michael Jackson killed himself with Propofol. The same medicine we use here on patients, but we use it with an anesthesiologist who's managing the dosing and monitoring the airway and saturation. Michael Jackson did it to himself and basically shut his brainstem down and stopped breathing. So he suffocated. Propofol is an amazing drug to put people to sleep, but you don't want to go too much, otherwise they stop breathing. So we have to balance too much versus too little. Too little, the patient feels pain. Too much, the patient stops breathing. And I would rather the patient feel pain than stop breathing, because feeling some pain isn't going to kill you. Stop breathing is. So we like to err on the side of safety when it comes to that balance, and that's exactly what we do. So somebody has a little bit of pain during surgery, they can forgive you later, but if they're dead, that's a whole different story. Safety first. All right, this is our last of these three cluster, and then we got two more. This is the L34. And again, this patient has just huge herniations in the foramen and lateral recess. I can feel it. It's like huge. So I'm going to use the dilator. This is one of the tricks of our procedure. You can actually shove the herniation back in, right? Because we're actually going right through the tear, and I'm going to shove this herniation back into the disc. And then we're going to take the herniation out from inside the disc. And that's called the inside-out technique. And again, that was Dr. Young's technique. You got a shot that I learned from him, as opposed to Dr. Haglund that promotes the outside-in technique, which is not as safe, in my opinion. I don't use the outside-in technique. The outside-in technique doesn't deal with the annular tear at all. And that's what most endoscopic surgeons around the world use. They use the outside-in. So they're actually not doing what's necessary to get rid of back pain. They're only addressing the herniation that's in the foramen, the neuroforamen. Okay? And they're going in the neuroforamen and they're looking and they're going, there's the herniation against the nerve root. But they don't understand the whole concept of inflamed annular tear as being the source of back pain because they're not addressing it. So, and in the United States, there's not many surgeons that train in endoscopic surgery. There's only a few of us, maybe at most 10 of us that do lumbar. I'm the only one in the United States that does thoracic discs, and I'm the only one that does cervical discs anteriorly. So of the 10 endoscopic surgeons in the United States currently, all 10 just do lumbar, lower back. And like I said, around the world there's probably 200 endoscopic spine surgeons. So there's more endoscopic spine surgeons outside the United States than in. So that's kind of concerning because the United States has always been the leader in medicine. But now you can see where we rank worldwide. I think 32nd or 34th, basically last of the developed countries. It's shameful. And a lot of that in spine is because the implant companies, the companies that sell screws, rods, and cages, they don't want to lose that business. So we're behind, and we're getting further behind while other countries are realizing the value of this type of surgery that we're doing now that doesn't involve implants, and it saves a lot of money and a lot of time and a lot of complications that patients don't have with this type of surgery that they do have with implants. So unfortunately, our system is corrupt, completely corrupted. And the only thing I can do is make everybody aware of it, but I can't fix it myself. The people have to fix it. Why is my pedal all the way over here? We have two pedals, right?
Yes.
Okie dokie. So, what should we talk about next, Diego?
Well, we just got a new question from YouTube.
All right.
Will the patient remember the periods of pain and movement?
Will the patient remember the periods of pain and movement? Great question. So, anesthesia means really a couple of things. Everyone thinks anesthesia means you're asleep, but it doesn't just mean you're asleep. There's 3 things to anesthesia. Well, 4. But one of them, the 3 things that have to do with the brain. One is being asleep. The other is not feeling pain. We call it analgesia. And the last is something called amnesia. So, sleeping, not feeling pain, and not remembering. Now, to get to get sleepy and no pain, you use Propofol. But Propofol, does Propofol have amnestic effects? No.
Yes, it does, but
Not as good as Versed? Huh?
not as much pain effects as you think.
Not as much pain. Yeah, so there is some amnesia with Propofol, but we give patients sometimes a little bit of Versed to help them forget. And it really works. It's pretty amazing. I don't know how it works exactly, but yeah.
What do you use to have the patient forget?
Well, Propofol is what we use to put people to sleep and not feel pain because they're so deep asleep, but it also works to help them not remember, amnesia. But if we need to get a little more amnesia going, we use Versed. It's a benzodiazepine. It's a benzo, right? Yeah. Benzodiazepine. It's a category of drugs that, if given at the right dose, it puts people basically to sleep. You may know benzodiazepines as things like Klonopin or clonazepam. Xanax, the most addicting drug in all of medicine. Valium is another benzodiazepine, longer acting, so it's not as addicting, but yeah, Versed is a IV version, and it's given IV and it's metabolized quickly, but it's really good at preventing people from remembering the surgery. So. So basically, what a lot of patients, when they come out of the surgery, their pain's gone. They think maybe I gave them something for pain, but we didn't. We gave them Propofol, which puts them to sleep and helps them not remember. But as soon as the Propofol wears off, they're awake, and there's no pain relief effect of Propofol. There's no durable elimination of pain. It doesn't work on your pain receptors like the opioids do at blocking pain by binding presynaptically to those receptors, preventing the action of the neurotransmitters in the pain pathway. Long story short, Propofol is not a pain medication, really, is what the anesthesiologist was saying, and I agree. Why do people abuse Propofol? Do you know? Like, why would Michael Jackson abuse it? Just to sleep? I mean, what's the reason people do it?
It produces it produces a sensation of having a very good night's sleep.
So there,
Very deep, satisfying sleep
Yep.
compared to the other sedatives.
all right, so there it is. Propofol, people abuse Propofol because it gives them a deep, satisfying sleep. I guess they feel very rested when they wake up. So if you have a bad conscience, you do things in life that you feel bad about, maybe you don't sleep well. I sleep beautifully every night. But some people do things they're not supposed to do, and they don't feel good about it, and they need something to help them sleep. And I don't mean that for everybody. Not everybody on sleeping aids has a bad conscience. I'm just talking about Michael Jackson in particular.
Actually, I have personal knowledge of that.
Really?
Michael Jackson, yeah.
Personal knowledge of his
Death and everything. Yeah.
of his death. I thought you were.
Why he used propofol and Conrad. That was all
Yeah.
the biggest thing.
Yeah. Oh, really?
If you want to talk about it,
No. We don't need to talk about it. But I don't want to get off on a tangent. But just the point that people need to understand are drugs are, mind-altering drugs are abused, and propofol is one of them. And it's very dangerous, I could save a lot of money not having an anesthesiologist and just have a nurse administer the propofol. But what I would be doing is risking the patient's life. And I don't believe in doing that. I don't think that's right, ethically and morally. God forbid something happened and the patients had difficulty with their airway and they died. I would never sleep well, knowing that I did that to save money, to put into perhaps my pocket versus, taking care of my patient to the best of my ability. So that's why I've always had an anesthesiologist for these surgeries. I don't mess around. It's too serious for me. Somebody dying is not acceptable. I've never had a patient die on me ever in 26 years. Other surgeons have, and it doesn't seem to bother them. But for me, I could never live with myself if I was the cause of someone's death because of my negligence, because I was trying to save a few $1,000s, That's not acceptable to me. I'm just a bit old-fashioned, I think. So we're using the laser to clean up this tear. You can see just how much nuclear material, all the blue stuff, is involved in this herniation. And the white stuff is the annular tear, but this is all herniated disc right here, all of it. We call this part of the herniation interposed, spelled I-N-T-E-R-P-O-S-E-D, because it's interposed within the annular tear. There's a piece stuck to the annulus right there. That's what I'm talking about, being the debridement is really removing the nuclear fragments that are stuck to the annulus from inflammation. It's the inflammation that causes that adhesion. So this is clear evidence that there's a lot of inflammation going on in this disc. And again, it's the inflammation that causes the pain. So this is taking a bit longer than I thought it would because there's so much of this interposed disc herniation. People ask me what's the difference between a herniation and a bulge. This is the bulge part of the disc herniation. Everyone's focused on the herniation part that's outside of the disc and in the foramen pushing on the nerve root. But that doesn't cause back pain. It's this part that causes the back pain, the part of the herniation that's stuck in the annular tear, the part that's contained within the disc still, the disc proper. So are bulging discs problematic? 100%. But unfortunately, you talk to 99% of spine surgeons and they say, oh, you don't need surgery on a bulging disc. Well, there's no way to get rid of this without the surgery. So they're basically condemning patients to live a life of pain. And then I see all these people on Facebook, like, in so much agony and pain, they can't live a normal life. They can't hang with their kids. They're crying all the time. They're depressed. They're on multiple drugs, you know, trying to eliminate the pain. Their lives are ruined. They can't go to work. They can't have good interpersonal relationships. They can't go out and be active and do the things they enjoy doing. All that, they've given up all of that because the doctors don't understand where the pain comes from. And then I go on Facebook and I try to explain it to them. And these trolls and these other sites, they come in and they tell me, stop lying to people about the cause of back pain. You know, people just don't want to believe it. It's incredible. Here's a board-certified neurosurgeon who's cured thousands and thousands of people of pain, trying to help people, and yet the trolls don't want me helping people because they want them to stay, these people to stay in pain. Have you heard of anything so insane? These are Facebook support groups for people suffering with chronic back pain and sciatica or pinched nerves, and they chastise me for trying to help people by educating them about what we've learned and the advancements in spine care, because we can actually cure their pain. Now that's what keeps me awake at night, are people like that, if anything does. Why have a support group to help people overcome their pain and suffering when you don't want to help them overcome their pain and suffering? All you want to do is sell products to them and keep the truth from them. Anybody have an answer for me? Because that's something I'd like to know. That's my question for the audience. I answer the audience's questions all the time. Maybe the audience can answer my question for once. So we're going to expose the evil in the Facebook support groups. That's going to be my mission. Right? Anyone ever see the Blues Brothers? I'm on a mission from God. If you haven't seen the Blues Brothers, you got to watch it. It's got probably one of the best car chase, destruction of property scenes of all movies of all times. Wouldn't you say? It literally has the biggest car chase scene I've ever seen in a movie. It set the bar. And besides, they got Aretha Franklin, among other performers, when she was real young. She's in that movie. So if you like Aretha Franklin, you got to go watch the Blues Brothers. She's amazing. And that's really her. I mean, it's really her in the movie. And she sings and performs. It's incredible. I know they got a movie coming out about Aretha Franklin right now. Right? What? Thank you. Music to my ears. Any other psychotropic drugs here? Any others? You get, what about the Versed? Huh? Come on. All right. Do we have enough for today? Doc? All right. Yes, you have a question, Diego?
Yes, we have a question from YouTube. are medical grants out there to get these kind of procedures covered?
Yeah, great question. Are medical grants out there and available to get these kind of procedure covered for somebody who can't do it? I'm not aware of any. But if I were you, I'd talk to your congressman and tell them you're really unhappy. Talk to your state senator. Tell them you're unhappy. You want coverage, you know? The PPACA, why doesn't it cover it if it doesn't? So you got to be an advocate for your health. Unfortunately, the insurance companies don't want to pay for anything elective. And this isn't like life-saving brain surgery where you're going to die of a brain tumor if you don't have surgery. They call it elective, but it's not really elective because you can elect when to have it, but it's not really elective. So I would talk to your senators, I would talk to your state senators, I would talk to your congressmen. I don't know what insurance you have, if you have any at all. There is something called vocational rehab. It's very important. Keep that in mind. Every state has it. It's basically state funding to help pay for medical care for people who need it that are out of a job and are willing to go back and work. So if you want to work, but you can't have a job right now because you're hurting too much, you're unable to work because you have a medical condition, vocational rehab will pay for you to have that treatment so you can go back to work. I think vocational rehab is really a good opportunity to look at. Every state has it. Florida has it. You just have to apply. I know in Brevard County where we are that there's vocational rehab office. I think it's in Vieira. I'm not sure. But you just look them up on the internet and, basically go over there and tell them, look, I found a way to get cured. It's for the Duke laser disc repair. I can get back to work, but I need to go see Dr. Duke. So for those of you that are asking, Duke Spine Institute does offer free MRI review. So if you have an MRI of your back or your neck and you'd like our free second opinion, I'm actually the one who reviews them, Dr. Duke Majan. I review all of them myself. And it doesn't take me long to do the review. It's usually under a minute, as long as Luis prepares everything, which he does an amazing job. So if you fill out the form online with your history and you get us your MRI uploaded onto our site or mail in the CD, either way, we will review your MRI for free and we will give you our recommendation for treatment. Once you have the recommendation for treatment, you can go to vocational rehab and you can tell them, look, I have a recommendation for treatment with Dr. Duke Majan. And he feels that he can fix my back or neck, whatever part of the body it is, and I can get back to work. And that's really what vocational rehab is all about. Getting people back to work, getting them healed so they can go back to work. Aside from that, we need some more irrigation, I think. Aside from that, there's always the GoFundMe. GoFundMe is quite amazing. It's a website that allows you to basically ask people for help, financial help, to get medical procedures. And GoFundMe basically will put your campaign for you to get your surgery out there on your GoFundMe page. You have to create a page. You have to tell them what it's for and tell a little bit of bio about yourself. And basically a GoFundMe account is another way you can ask for, anonymous donations to help you get the medical care you need. My goal at Duke Spine is to eventually have that kind of a charity that we have that people will donate to, that we can actually set that money aside for people who need financial assistance. But right now we don't have something like that available. We don't have a program like that. But I could see that happening in the future. We need, I would write to Mark Zuckerberg. That's what I would do if I were you. If you need medical care and you can't afford it, write to Mark Zuckerberg. Write to Bill Gates. Tell him you're hurting, you're suffering, and you have a way to get it fixed. It's just you don't have the money. Let them help. They have charities. They have literally billions of dollars at their fingertips, at their disposal. And they talk about helping people and doing charity work, but this is how you could do it. Right here. Pay for someone's back surgery. That's what I'd like to see happen. I'd like to see these super rich guys do something about it, about their money. And women. I'm not going to discriminate. Rich men, rich women, either way, doesn't matter. Ask for money. They got more money than they know what to do with. Okay? So give them purpose. Give them something to do with their money that means something to someone else. These people have more money than they'll ever be able to spend in their lifetime. So they just need a good reason to spend it on you. And if you reach out to them, there's a good chance they'll respond. These surgeries are not that expensive. They're less than a new car. I mean, it depends on what kind of car, obviously, but I don't think there's any cars that are more expensive than our surgeries. So for the price of a car, you can get your back or neck fixed, that, pain that you've had for 20 years, 30 years, and get on with your life. By the way, if you think the new car cost is high, spinal fusions are about 3 times more than these surgeries. Much, much more. Stand by. We're just about done here. I just want to grab that little piece out. Looks good. All right, done. I'm done. Our fusions, when we do them, multi-level fusions, they run $200,000 to $300,000. Scope off. Same price as having it done in a hospital. We're not more expensive. But think about that. That's a lot more than a laser, which is about 1/10 of the price. So this endoscopic surgery, because we're not using screws and rods and patients aren't staying in a hospital, this stuff is a lot less expensive. And I don't know if you know this, but a lot of times hospital surgery, you're going to get a complication like a blood clot or pneumonia or infection, and then you're back to the hospital for more treatments. We've never had a complication with this surgery. We've never had to send a patient back to the hospital. Okay? Come on in. I've heard of people having fusions down the road at one of our competitors that does a lot of fusion surgery, and patients have gone to the ICU after spine surgery with the surgeons down there, and they were admitted to the ICU unit for 2 weeks because of complications from simple fusion surgeries, which we do outpatient, by the way. And I've even heard of people dying from their spine surgeries down in the hospital. Where are we at here? I'm not seeing the x-ray. Guide wire. So for a patient to die from, getting their back fixed, that's horrible. But it happens all the time. Especially with open surgeries like laminectomies, discectomies, fusions, artificial disc. All those surgeries, people can die from surgery, and it happens. Let me tell you a story. There's a surgery center down south, okay? And this patient went there and had an ACDF, right? And the patient went in, and the surgeon cut and started opening, and then suddenly stopped the surgery before they did anything. They were just what's called dissecting by the esophagus. So, what happened was the surgeon cut the swallowing tube, all right, with his scalpel and caused a hole to form. Recognized it and said he tried to sew it closed. And then he closed the patient up, sent the patient home, okay, after cutting through the esophagus. Well, the patient's esophagus swelled up so much that he couldn't swallow, and he was drooling, just like drooling, couldn't swallow, getting dehydrated. He was going to die like a dog. So they tell him, go to the emergency room the next day, right? So he goes to the hospital ER, a little bit more maybe. He goes to the hospital ER, and of course they admit him and put him on IV fluids and do an esophagram. He had 8 holes in his esophagus, 8, by this surgeon, trying to do a simple ACDF. They never even got the surgery done. Shot? So, should the surgeon have caused 8 holes in his esophagus? No. Never. Should the surgeon have sent the patient home afterwards? No. They should have admitted him to the hospital. But guess what? They didn't want that complication going on their record. So they discharged the patient. Then, get this, the patient calls the surgeon a few days later when he gets out of the hospital. Actually, he got out 2 weeks later. And he said, what happened during my surgery? And the surgeon said, oh, nothing. I think the anesthesiologist may have injured your esophagus when he was intubating you. I mean, blatantly lied to the patient, blaming the anesthesiologist who wasn't there to defend himself. And that's not an anesthesia injury. That's a surgeon injury. I mean, just the kind of low-class dirtballs that are out there, folks. Just watch yourself. There's no integrity, no honor. And again, they sent this poor patient home totally below the standard of care. It's malpractice after injuring his esophagus. He should have been admitted to the hospital, put NPO, IV fluids, and monitored until that esophagus healed. Did they do that? Nope. They just sent him home, so they didn't have that hospital transfer and admission on their record. At Duke Spine, we've had 0 hospital transfers, 0 admissions. We don't do that to people. But there's a lot of incompetent, stupid, idiotic surgeons out there that are just greedy, and they're doing procedures they shouldn't be doing, and they do it for one reason, to get money. And it really pisses me off. So I myself, I'm a neurosurgeon. I could do aneurysm surgery. I could do brain tumors. I could do shunts. I could do anything in neurosurgery, and it all pays really good, but I don't. Why don't I do those surgeries? Because I'm not better than the people at the universities that do them all the time. And if I have a patient with an aneurysm or AVM, yes, I'm losing out on money if I don't do the surgery, but I'm going to send them anyway to the best doctor for that problem. And that's what I do. It's called being ethical. So unfortunately, there's a lot of incompetent spine surgeons out there that do surgeries that hurt people, and they know they suck at it, but they still do it because they have to make a living. Well, that shouldn't be the driver of doing surgery or treatment. Your driver should be, you know, you have the best fix in the world for that patient, you're going to give it to them. Okay? That's why I don't do aneurysm surgery. Actually, let me see if I can grab a little more. I don't do brain tumors. Okay, can I? Of course. Am I the best? No, I'm not the best. Are there a lot of neurosurgeons better than me? Absolutely. I'll be the first one to admit it. Okay, I'm a neurosurgeon, yes, but I'm not an aneurysm surgeon. I'm not a brain tumor surgeon. I'm not a pediatric neurosurgeon. Heck, I'm not even an idiopathic pediatric scoliosis surgeon. I don't do those types of cases. So I'm very focused on what I do the best, and nobody does it better than me. And that's all I do. I do those types of surgeries. And surgeons should do the same thing. They should all have a focus. And they should refer patients to better surgeons and better facilities than themselves when it's appropriate to do so. It's all about a man. They say, the old Clint Eastwood saying, and this applies to men and women. I didn't make the saying up. A man's got to know his limits. Okay? If you're a Clint Eastwood fan, you know what I'm talking about. And Doctors need to know their limits. And they should first do no harm. They should first not hurt patients with their treatments. Okay? Unfortunately, that doesn't always work out that way. But patients, you're on the receiving end. You're the one who's going to be hurt by that doctor if the doctor is not great at what they do. So my advice to you is do your research, know where to go, know who to trust, and go to doctors that have great results but also low complication rates, okay? And I think patients are doing that more and more these days. They're doing their research on their own. So sometimes I'll get into the disc like this and there'll be a big herniation that we pushed from the outside in, and you're looking at it and it's got this white stuff on it from all the scar tissue. All right, and that's what that is, and I'm trying to get it out. But it's so big, I'm going to have to take it out in pieces. It just doesn't want to come out easy. The nice thing about this surgery is I can actually see what I'm taking out. See, normally surgeons that do microdiscectomies, they can't see what they're taking out until it comes out because it's down a deep, dark hole. They're not looking inside the disc like I am endoscopically. We're actually inside the disc, taking out the pieces that need to come out and leaving everything else that doesn't need to come out in there. But I can make choices by looking down the endoscope and feeling with my pituitary or my laser. See, normally surgeons can't do that because they don't see inside the disc like I do. Only endoscopic surgeons can see inside the disc. It makes it a much more precise surgery for the patient. So you only take away what needs to be taken away and not everything. Okay? Any questions? There's the tear. Look at that piece of granulation tissue right there. You see that little pink area? Right at the tip of the laser right there? That pink thing is where the pain comes from. It's called the pain generator. It's literally a nest of granulation tissue, inflammatory tissue with nerves and blood vessels that are causing this patient's back pain. And we just zapped it away.
We have a new question.
Sure.
YouTube asked if people knew the kickback surgeons get and what motivates them due to procedures with instruments, what would the public have to say about the level of trust?
Yeah, great question. So the viewer has asked me if the public knew about the kickbacks that surgeons were getting, let's just say spine surgeons, because I don't know about other types of surgery, but what would be the public's opinion about it? It would probably be pretty low, because I know about it and my opinion's very low. So let me start by saying this. Let me give you some numbers to digest, okay? Because it's all about facts and numbers. There are 6,000, roughly 6,000 spine surgeons in the United States. 3,000 neurosurgeons, 3,000 orthopedic spine surgeons. And it's 50-50 orthopedic versus neuro. Really, it's about 50-50, okay? So you got these 6,000 spine surgeons. Now, there's an old saying, and many of them are close to retirement. They're not really doing much surgery, okay? So there's an old saying, and this saying is a truism. A truism means it's a saying that's true. So there's a truism in spine surgery. And here is the truism. 10% of the spine surgeons do 90% of the spine surgery. 10% of the spine surgeons do 90% of the spine surgery. What this means is that a small number of spine surgeons are actually responsible for doing 90% of the spine surgeries. Okay? Why is that? Because the other 90% of spine surgeons, many of them are close to retirement. They don't really operate that much. They just do IMEs, or they do clerical work or second opinions and peer reviews and things like that. Okay? And of the spine surgeons that are practicing and doing surgery, many of them just work so slowly they don't do that much. They don't get a lot of cases done. So you have 10% of the spine surgeons, so let's just say 600 out of the 6,000 that are super aggressive and do most of the surgery. All right. Of those 600 spine surgeons, who do you think the companies that sell screws and rods to go in the spine, who do you think they target? Do you think they target all spine surgeons, or do you think they target the 10% that do 90% of spine surgery? Well, they target the 10% that do 90% of spine surgery. That's where they get the biggest bang for the buck. Because if they can get those 10% of spine surgeons to put their screws and rods in patients, they're going to make billions of dollars off of those surgeons every year. And that's exactly what happens. So if you look at the 10% of spine surgeons that do most of the work, you can actually find this if they ever give a talk or ever publish a paper. You can find that they have what's called a disclosure form, a disclosure. And what a disclosure means is that they are disclosing financial relationships that they have with the implant companies, the companies that manufacture and market and sell screws and rods, okay? So I'm telling you, the surgeons that give talks and lectures to other surgeons, the surgeons that do most of the work, those surgeons have payments coming in to the tune of millions of dollars, some of them astronomical amounts per year, that they're getting paid by the implant companies, okay, to be what are called advisors, to be speakers, to be developers of technology. There's all these titles, all right? And that's those relationships between the spine surgeons doing most of the surgery and the implant companies were the target of the federal government's investigations into inappropriate relationships between surgeons and implant companies, okay? So, but guess what? The implant companies stymied those efforts, okay? These are the Medtronics, the Johnson & Johnsons, the Alphatechs, and the Nuvasive companies. All these companies used to be Synthes. They all ran interference in that whole process so that their relationships would not be exposed and nobody would go to jail basically for kickbacks. But they are kickbacks. They are kickback schemes. And the surgeons get paid obscene amounts of money to promote the use of screws and rods. And the thing about it is that these surgeons that are getting the kickbacks, they're the ones in charge of teaching the next generations of surgeons. So that they're teaching them to put in screws and rods. And that's why they're getting paid. It's for their position of influence that is the basis of that relationship between the companies that pay millions of dollars a year to them for their advisory roles or whatever they call it, okay, research and development positions. Okay, but it's really just a way of kicking back money to surgeons for promoting the use of screws and rods and cages, okay? Now, did I ever get involved? No. Why not? Because it's illegal, and I don't believe in breaking the law. Okay, I believe in following the law. But there's a lot of surgeons who do. There's more inflammatory tissue right there. That's the source of the pain. It's all the little nerves in there. But there are a lot of surgeons who do. I believe in making an honest living. I don't want to go to Club Fed. Hey, I'd rather go to Club Med. I know my patient will enjoy that when he wakes up and watches this. Yeah. So I think the public would be very upset, and that information is available. All you got to do is type in a surgeon's name and look up disclosure, financial disclosures on Google, and you probably could find some information where they're talking about how they're the consultant or lecturer or whatever it is they do, however they package that financial incentive. Okay? But the government's not doing its job of stopping it. Now, in the defense of industry-surgeon relationships, you know, the industry does need surgeons to be champions of technology, because without surgeons, you can't develop surgical implants or instruments. So I think there is a need for it. And how do you structure that relationship so that it doesn't create bias for, you know, services and supplies that could potentially harm the patient? I don't know. I'm not an expert on the ethics and legal structuring of relationships. I don't know what to tell you. Maybe there's a way to do it so it's fair and so that it achieves the goals that are in the patient's best interest. I'm sure there's a way. I just haven't thought much about it because I don't get involved. So I'm too busy doing other stuff that's helpful for patients, like the surgery. Great question. I'm glad the audience is paying attention. We are just about done. This is the L3 disc. This is the long surgery. I think this is our longest surgery of the day. Right, Luis? But the great news is when he wakes up, this pain that he had before will be gone. And I think his leg pain will be gone. I'm really excited for him. It's just, we got one more disc to go. I think another 15 minutes, doctor, and we'll be done. Look at what a nice job the laser's done. There's a lot of scar tissue here. This is the end of the tear right here. You can see it. And there at 12 o'clock is the epidural space. This to me was one of the worst discs. And there's a lot of scar tissue indicating this injury is old. So if you look at these discs that we've been treating so far, you can tell by looking at the nucleus pulposus, the blue stuff, that some of it's better preserved than others. In other words, some of these disc injuries are older, some are younger in terms of years. Some are more damaged than others, but they're not all equally damaged, okay? This is the absolute back of the disc. This is the posterior annular tear I'm debriding. Just about done. And we got one more to go. I think this patient's going to do fantastic. Again, he came from Fort Lauderdale. He's about 2 hours away. And there's nobody there that does endoscopic laser surgery like we do. So he found us on the, I think through a family or friend, actually. I don't want to say who, but I believe it's a family member who had laser surgery with me a year ago, and that family member recommended the laser surgery to this patient who's been suffering. How many years has he been suffering? Anybody remember? How long has he had his pain? I think it's like 12 years or something, right? All right, any more questions for me? I'll be done in 10, huh?
We actually have a question for your anesthesiologist.
All right.
Does he or her handle any patients with severe sleep apnea?
Does he or her, it's a he, and does he ever handle patients with severe sleep apnea? I imagine yes, right?
Yes.
You probably would rather have them intubated though, right? Maybe, and CPAP and... Yeah, he said it depends, but he does handle patients with severe sleep apnea.
He also asks, is it safe to go under general anesthesia?
For sleep apnea, is it safe to go under general anesthesia? Huh? Yeah? Yes, you can. You can go under general anesthesia even though you have severe sleep apnea. You just have to be monitored more carefully afterwards, and it's all about the afterwards care. And if you have a CPAP machine, bring that with you wherever you go to get your surgery. Make sure you bring your CPAP machine. So, And if you don't know what I'm talking about, you better go get tested and get a CPAP machine. Because if you have severe sleep apnea, before you have any kind of surgery, you really should have a CPAP. So when you wake up, you know, you have that machine to help you breathe. Just about done. The last few seconds here. And again, this is L23, right, Luis? You can see the offset of the vertebral bodies. There's definitely some listhesis. I was going to say there's definitely some Luisis. But there's... How's our irrigation doing? Because I'm getting a lot of bubbles. Huh? It's good? All right. Take that. Let me see. Nope. Let me see. A nerve is going to be right up in there, but again, it's covered in ligament and fat. Can't really see it. Just about done. I just want to make sure I get all this. If you notice, the area that I'm working on disappears because it's being broken up into small little pieces through a process of vaporization. And then there's also the pressure wave which blasts it. So if it was just vaporization, you would see it disappear but stay in the same place. But because we have a pressure wave, it's like getting broken up, and it's getting that, what is that thing called? The pressure washer? It's getting blasted at the same time. Okay? So it's getting broken up and blasted, and then the irrigation sweeps it all out. That's it.
Nice on, please. Drop off. Patel here.
Yeah, we need Patel. Great point. We need him here in about 10 minutes. Let me have the thing. The dilator. I really hate using this stuff. You know? Do we have any more irrigation? Oh, that's good. Cleared it out good, huh? So this is a long case. Normally they're not this long. The reason it's so long is we're doing 5 discs. And normally we don't do 5 discs, but for some reason we've had 2 patients in the last 2 surgery days that have been 5 discs. So, you know, and that's something else to talk about. I think it's important to recognize that one of the reasons spine surgery doesn't work for people is that the surgeon did not fix all the discs that needed to be fixed. Whether it's fusion, artificial disc, lateral, please. So we call that undertreatment. The patient's undertreated. They're not treated completely. Their disease is not completely treated. You know, if you have a tumor in your body and the surgeon undertreats it, that means that they did not take all of it out, or maybe they took 50% of it out, or they did radiation afterwards, but you're supposed to get 10 grays of radiation, you got 7. So you're undertreating the disease. So if we think about it with tumors, it would be not taking out enough, or it would be not radiating it enough, or it would be not giving enough chemotherapy. So you're basically doing too little, and you're leaving behind disease. So in spine surgery, if the surgeon doesn't treat all the bad discs that are causing pain, you're still going to have pain. And that happens all the time, folks, all the time. I can't begin to tell you how often it happens. It's common. And the reason it's common, it's not the surgeons are mean and bad and evil. It's that treating more levels means more work, longer work, being in the operating room longer, getting tired, missing that tee-off time at 2 o'clock. Okay? So surgeons are, unfortunately, for the most part, extremely selfish and greedy people. It's truth. I know a lot of them. And they don't really, unfortunately, they don't necessarily put their patients' interests ahead of their own. There are times where they actually will put their own interests ahead of the patient's. And that results in the patient getting undertreated. So for many of you, you've gone to the doctor's office, right? And the doctor doesn't spend enough time. They don't take the time to really understand what's going on. And basically, that's part of the whole undertreatment process, is not making the right diagnosis right away. So if the doctor doesn't spend enough time with a patient to make the right diagnosis, how are they going to make the right treatment? So if they're not spending enough time making the right diagnosis, then you imagine in the operating room when you're asleep, they're going to do even worse. They're going to spend less. So it's very important that the doctor invest in their patient's well-being. And unfortunately, I'll be honest, I have no problem saying this because it's true. A lot of surgeons just are pretty selfish people. And by giving the patient more, they're taking away from themselves. Pretty weird, isn't it? I mean, if we got paid for every hour or every minute we spend with a patient, maybe they would spend more time doing their job properly. But because we get paid just a fixed amount for a specific type of surgery, he's a bit uncomfortable, but I'm okay with it if you're okay with it. I don't know where his level of sedation is. You want me to wait? All right. Shot. Long story short, because doctors are not paid on time, they're paid on the job. A lot of them cut corners just like contractors do. And the cutting of the corners can result in bad outcomes. All right, I'm going to have to pull this out. Yep. So that's why it's important to hire a good contractor, and it's also important to hire a good surgeon, because a surgeon is no different than a contractor. There's really bad ones and there's really good ones and everything in between. The difference is if your contractor doesn't do their job right, maybe you don't pay them, But with surgeons, they get paid just for showing up and doing the job, but it doesn't matter about the quality of the job. There's no inspector, that checks the quality. Okie dokie, artichoke. We are about to do the last disc. It's a good thing because I'm due for a refill on coffee. And when it comes to me doing surgery versus drinking coffee, I'm sorry, but a man's got to have his priorities, right? After all that talk about sacrificing, I'm kidding. All right, why does there look like schmutz on the lens? Luis, what kind of a schmutzy lens are you giving me? Huh? Is that clear? We don't have a lens issue, right? I just want to make sure. This is a totally degenerated disc. Look at that. There's no disc left. On the left is inflammatory tissue in the end plate. On the right is inflammatory tissue in the end plate. And a little piece of herniation in between. But there's just no disc left. So, will I get rid of the pain here with this procedure? 100% yes. Why? Because getting rid of the pain has nothing to do with whether there's disc left or not. It has to do with whether you get rid of the source of inflammation. And that I'm planning on doing. All right, take. Wait. There's nothing to zap yet. I gotta find the nidus of pain.
We have another question from YouTube.
Yeah, I kind of like that though. The nidus of pain. You like that? The nidus of pain. Huh.
Our commenter asked, in this view, can you show us the nerve?
In this view, can you see the nerve? Is that what you're asking?
Yes, or is it hidden?
No, it's hidden. It's protected behind the walls of this tube. Okay? So I'll tell you. Look at 12 o'clock. You see the white tuft? So that wall of the tube is blocking the nerve called the traversing nerve, which is the one that runs, it's running up and down it's running down to the next level, basically. And then to the right is the exiting nerve. So there's two nerve roots. One is at 12 o'clock, and the other one is at 3 o'clock over here on the right side, hidden behind that wall. And by the way, that's the way we want it. We don't want the nerves in the field of view. If the nerves are visible to you and me, then I could damage them because my laser or my instrument could accidentally hit it. So this tubular retractor is doing its job of protecting the nerves by hiding it from me and my instruments. You know what I'm talking about, folks? Think about me as being the big bad wolf. What is it called? The wolf that, werewolf. You know, at midnight, full moon, the werewolf comes out. But you want to lock away your children. The werewolf wants to lock away his children or her children so that they can't get them when they turn into a werewolf. So I'm bringing all these dangerous instruments down this tube. I don't want those nerves anywhere near where I can accidentally grab them and hurt them. So I've locked them away. I don't go out there and say werewolves exist because Dr. Duke's talking about them. I'm just using that as an example. All right? If you couldn't tell, I watched, what is that series with Kate Beckinsale? You guys know what I'm talking about? The werewolves and the vampires?
Twilight?
No, not Twilight.
Are you talking about Twilight?
No, not Twilight. Kate Beckinsale. She's that British actress with the black hair dressed up in tight leather. Huh? No, not Van Helsing. It's not Resident Evil. That's Alice. Anyway, I can't believe that these movies that you grow up with, people don't know about them. Someone will get it.
Is that movie Underworld?
Yes, Underworld, yes. Underworld, thank you. I even watched it last night, but I didn't pay much attention to the title. I was too busy looking at Kate. Yeah. If I was a werewolf, I'd definitely want to go by way of her hand. All right, little humor. Little British humor, because it's like a British cast and crew. Okay, we're just about done. I need 5 more minutes to go, and we're at the back of the disc at L12, and this is the tear. This is the interposed nucleus that I'm getting rid of. It's totally scarred down to the tear, and this is where all the pain's coming from. So when I clean this up, the pain will be gone. Just another piece of herniation right there. And let's get a fresh pot of coffee going. Okay? Diego, will you have Deb come out and make some? Because I need some.
Sure, I'll make you
In a bad
some.
way. Take. Maybe Deb's watching. She does a great job with coffee. Some of you may know Deb. If you've reached out to Duke Spine, she may be, she's your first point of contact if you've submitted a form online. Deb, she's the one who gets the emails out. What's going on with my irrigation? Are we at the end of the irrigation or what? Okay. It's just, I'm having a hard time with it. So can we check it to make sure there's still irrigation? Still good? And it's pumped up? Maybe a pumping issue. I had a feeling it would be. Thank you, though. We're just literally 2 minutes away from being done. So we don't need a whole lot more. Some great questions today from our audience. I've enjoyed answering them for you. And if you've tuned in for the surgery, is 5-level Duke laser disc repair. And is Dr. Patel anywhere nearby? Who's bringing his machine? Okay, good. So Dr. Patel is going to come in and do a RFA on the left side. Our patient has facet pain at L45 and L5S1 on the left side only. Okay, we're done. Take that. Let me just look one more time. Yeah, the nerve root's right there. You see that white thing? Kind of whitish thing? That's the nerve root. It's surrounded by loose tissue, loose connective tissue. Hold on. Let me see here. Let's see the grabber. That's the bone right there, by the way. The vertebral end plate. Looks good. No. Okay, we're done. Let me have the roly-roly. The roly-poly. Take. Yeah. You want to? You want to? What do you want to do? I think so, right? Yeah, I think on that one only. All right, just lay still. You're waking up. So great anesthesia, like perfect. Everything's done. Your surgery's over. Just lay still. We're almost done. So I want to show the audience. We did 3 incisions. They're all about 7 millimeters, and we fixed 5 discs. You ready? Don't move. Lay still. Okay. Read Anita. We need to keep him asleep because he has to do the RFA. All right. I'm going to come to the studio where we broadcast. I have a Raytech off, and I'm going to answer questions. So if you want to type up your questions for me, I'll address them face-to-face with you live in about 4 minutes. So start typing, and we'll show you a video animation of what we just did. It's the Duke laser disc repair. We did it for 5 discs, but Diego will run a video animation showing you the Duke laser disc repair for the lower back.
All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. "30 years ago, I used to run motocross, cross country, did a lot of different things. But one of the biggest things I did was had a bad motorcycle wreck during that, and did an end over the handlebars, and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for the matter of an hour, just the way the steering wheel is positioned on the RV, it just sends excruciating pain across my back, gets down to my hands where my hands are numb. Me and the wife, we have to pull over, rest stop. After 2 hours, it's incredible. I just got to get up, take a break, shake my hands. Well, if you're going on a long trip, 2 hours don't get you very far. Just like lifting up this, I was having a hard time getting into my engine compartment. Just every little thing that you take for granted seemed to become a bigger problem and bigger problem as far as my neck. I went to Dr. Duke's to try to get fixed, and he did an expert job. Looks pretty good. Fixed it all up for me. Went in through my neck, went around to hit the back of the spinal cord. I still don't know how they do it. Unbelievable. But no scars, didn't hurt at all. As you know, when I woke up, it was totally painless. My surgery was done on a Thursday. I went back to work Monday. Pretty awesome. Once I've gone to the Duke Spine Institute, it's amazing. Once you take that pain level down, it's like, whoa, there's nothing. I mean, it's night and day. I mean, I just can't even describe it, how good it is. You know, I feel like a new man again. Now that I'm back driving the bus again, it is fantastic. Now we can get behind the wheel, drive for a good 8-9 hours, and then take a rest where I want to and not where I have to. What a difference. Fellas, I'm telling you right now, if you've got the pain I've got, you call me. We'll talk. Anybody can call me anytime. 321-403-8757. We'll talk about the pain. If you've had this, you're gonna want to get rid of it. What a great place right here in Rockledge, Vieira, where we can get rid of it right there. I wish I had known this years ago, but I did laser, Duke Laser Disc Repair. It was great. My name's Randy Quick, and if I have anything else, I know where I'm going. I'm going to Duke Spine Institute. All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. "30 years ago, I used to run motocross, cross country, did a lot of different things. But one of the biggest things I did was had a bad motorcycle wreck during that, and did an end over the handlebars, and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for a matter of an hour,
return to work.
Just the way the steering wheel
Shock
is
surgery works.
positioned on the
AP,
RV.
let's see where we are.
It just takes
We're almost done, I
some
promise. We're gonna put
excruciating
1,
pain
2.
across my back. Gets down to my hands where my hands are numb. Me and the wife, we have to pull over, rest stop. After 2 hours, it's incredible. I just got to get up, take a break, shake my hands. Well, if you're going on a long trip, 2 hours don't get you very far. Just like lifting up this, I was having a hard time getting into my engine compartment.
Yep, you are good. Available in 3, 2, 1, and 1 second. You are live.
Hi there, I'm Dr. Duke Majan, and we're here at the Duke Spine Institute. We just finished a 5-level Duke laser disc repair on a patient who had really a combination of back pain and right leg pain, numbness, tingling, and weakness. So this is a long surgery. Normally we stop at 4 levels, but I hate to make people come back and do a second surgery. So as long as I feel that the case can be done safely for the patient, I always like to try to squeeze that 5th level in if they need it done. In this case, he did. Before surgery, I was looking at his MRI, and what I saw was that, just ignore the metal, but I saw that basically he had 5 herniated discs. He had the bottom one, which is L5S1, the hardest to get to. He had L45, 34, 23, 12. All those discs had a tear and a herniation. And importantly, he was having pain not just in the sciatic distribution, but also in the distribution of the femoral nerve. So what does that mean? What it means is that the bottom nerves, L3, L4, L5S1, they make up the sciatic nerve, which runs from down the back of your leg to your toes. But there's another nerve that goes in your leg called the femoral nerve, and it actually goes kind of in the front, where the thigh is, in the front. And that's made up of L2 and L3, basically. And so because he had femoral nerve complaints and sciatic nerve complaints, I knew that we were dealing with multiple nerve roots going up as high as L2. So when I looked at his MRI and I saw huge herniations here at L12 and L23, I knew they had to be treated to get rid of the front of the thigh symptoms. So it was just a matter of paying attention to what the patient was complaining about and making it relate to the anatomy on the MRI and what I was seeing. So I also knew that his back pain was more in the lower back down here. This is like L3, 4, 4, 5, 5, 1. What he didn't tell me was that he did also have pain higher up at L2, 3 and L1, 2. So I ended up doing the discogram in the operating room before the surgery, and we were positive for back pain at the bottom disc, the one above it, and the one above that. I was a bit surprised that he also had back pain from these two because he really didn't complain about it before surgery. But in the operating room, he admitted to me and he said, yeah, I do get pain in that area as well. So his pain in his back is more common in the lower back, but he also had the upper lower back where he had pain. So we fixed all 5 discs. I believe he's going to come out of this surgery without back pain and without the right leg symptoms anymore. I think he's going to feel like $1 million, and everything went without a hitch. We lost probably 5 milliliters, maybe 6 mils of blood. Think about 1 mil of blood is 20 drops. So we didn't lose more than, say, definitely we didn't lose more than 100 drops of blood. So I think 100 drops is about right, 5 milliliters. Basically, this is bloodless surgery. We're not losing blood. The patients are going home on Tylenol and an Advil, basically. We call it's a oral version of Toradol. And that's it. We don't do narcotics for this surgery. There's no painkillers. There's no opioids. So it's basically just a Band-Aid. In this case, 3 Band-Aid incisions because there were 3 cuts. And the patient will be in a back brace for 6 weeks. No bending at the waist at all. And no lifting more than 25 pounds for 6 weeks. And then that goes up to 40 pounds. So,
cool.
Any questions?
Yes, we have one question from our app. This patient has had a spinal cord stimulator placed in them. Can you still perform surgery on L15?
Yeah.
S5 in this with her situation?
Yeah. So one of our viewers who had a spinal cord stimulator put in. And what's a spinal cord stimulator? Well, you know, we put them in here because there really are some patients that have no way to fix their spine with surgery, and the only thing you can try to do is cover up the pain. So a spinal cord stimulator is a battery that gets implanted under the skin, and it has wires that go from the battery up to the spine, and the surgeon puts some electrodes on top of the spinal cord and thoracic spine up here, and then they send magnetic waves and electrical impulses into the spinal cord and try to short circuit the back pain and leg pain signals that go up to the brain. Think about it. Your brain only knows that you're having back or leg pain because those signals travel up your spinal cord to the brain. If you block the signals, if you block the signals halfway up, they don't make it to the brain. The problem with stimulators is that, number one, they don't work that well, and when they do work, a lot of times they stop working. They stop working for two main reasons. Number one, you get this, between the electrode and the spinal cord, you get scar tissue growing in there, and that prevents it from getting enough contact with the spinal cord and transmitting that electricity down into the spinal cord. The other problem is they move. So the paddle may be put in here, and then over time, with standing up, bending, twisting, the paddle moves down, it migrates down. So in the end, you don't want a spinal cord stimulator, period, unless there's no other fix for you. Unfortunately, here's the big problem, folks. Spinal cord stimulators pay a lot of money. The insurance pays a lot of money for doctors to put them in. So Medicare pays about $26,000 to get it put in a surgery center. All right? So the problem is you got all these doctors jumping on that, trying to make money by putting spinal cord stimulators in. So all these doctors around the country are like spinal cord stimulators, and these are mostly pain management doctors who don't make surgery money. So that's big money. Normally they get paid $300 to do a shot. Here's a spinal cord stimulator paying them thousands of dollars. So it's just about greed, and it's got to stop. These spinal cord stimulator companies are just promoting their stimulators to the surgeon, to the doctors, mostly pain management doctors, and the pain management doctors are putting them in. We put them in too here at Duke Spine, but we save this and reserve it for like people that are so messed up they just can't even have surgery, which is extremely rare. Probably, if I had to guess, it's not even 1% of our patients, but like 10% of 1%. So it's like 1/10%. 1 in 1,000 of our patients ends up needing these things. So the problem is you go to these pain management doctors and they'll put them in everybody. You walk in with back pain, they'll try a shot, you still have back pain. Of course you do, because they didn't fix it. Then they're going to recommend a spinal cord stimulator. We had a guy here, I won't mention his name, but he's a pain management doctor, actually a couple of them, that were putting him in every single patient they could. And they made millions of dollars doing it. And that disgusts me, because I could have fixed those people and they never would need a stimulator. And once you get a stimulator put in, you can get an infection, and more importantly, you can't get an MRI most of the time, because a lot of them are not MRI compatible. So I'm sorry I went off on a tangent, but to answer your question, we could still do the laser surgery even though you have a stimulator. We can fix your pain most likely, and then we can get your stimulator out so you don't need it anymore. That would be the best possible outcome.
And that is all.
That's all our questions. So go to Facebook and subscribe to Spine Surgery Support Group. That's the Duke Spine Institute's Facebook group. There's no trolls. We answer questions with certified doctors who know what they're talking about. We're there to help people get an understanding of what's wrong with their back or neck and what to do to fix it. There's a lot of misinformation out there. That's why we have our app that's free. We have our Facebook support group, it's free. We have the Duke Spine Facebook page, it's free. We answer questions for free. We do MRI reviews for free. We do telemedicine for free. We do as much as we can to help people understand what's wrong with their back and neck for free, because people, it's nice not having to pay for something like that, okay? Doesn't mean you get less quality, you get the very best. I'm the one who does it, and I've been doing this 26 years. So you're going to get the very best in the world at this for free, just to help guide you and point you in the right direction. Have a nice day. We'll be back again in 30 minutes with our next laser. It's a 1-level L45, and then we got 2 more.